Hey, good morning, everyone. Good morning. My name is Jamie Kowalczyk. I'm the Chief of Staff and the Vice President for Strategic Operations here at Concordia University Chicago. I've written some notes so I don't get lost in my words, so I'm going to go ahead and start to read a little bit to you. Welcome to Concordia University Chicago. It is a pleasure to gather with you for this Leadership Symposium on Brain Health and Dementia Care, an event that embodies what is possible when mission-driven organizations come together across sectors, cultures, and even continents. We are honored to again partner with the Chicago Scots and Caledonia Senior Living and Memory Care. Our Center for Gerontology last hosted a symposium with the Chicago Scots in 2016, and it is inspiring to see how that early collaboration has grown into today's gathering. Our shared commitment to improving the lives of people as they age is made possible by our shared supporter, the Russell and Josephine Cott Memorial Charitable Trust, which has long been the primary funder of the Gerontology Center here at Concordia. We are grateful for their continued vision in advancing work that makes a difference in the lives of older adults and families. Today, we have a remarkable group of attendees, more than 90 registered across in-person and online participation, including practitioners, researchers, advocates, students, and community leaders. This blend of perspectives is essential because dementia care is not simply a clinical issue. It touches public policy, family systems, cultural identity, and the fundamental question of how communities care for one another. And of course, it is a privilege to have with us in person Gus Noble, President and CEO of the Chicago Scots and Caledonia Senior Living and Memory Care. Gus has been a steadfast advocate for elevating global perspectives on aging and memory care, and his partnership has been essential in bringing this symposium to life. Thank you, Gus. At Concordia University Chicago, we are guided by values that emphasize service, vocation, and the dignity of every individual. This symposium reflects those values. It invites us to learn, to question, to imagine, and to collaborate, because addressing the rising prevalence of dementia will require all of us working together with creativity, compassion, and resolve. Thank you for being here and for the work each of you does on behalf of older adults and their families. And at this time, I'm now delighted to turn over the microphone to today's moderator, Gus Noble. Thank you.
Thank you. Good morning. Thank you, Dr. Kowalczyk. On behalf of everyone here in the Christopher Center and watching online, I thank you and your team for extending such a warm welcome to the Center for Gerontology at Concordia University Chicago and for joining Chicago Scots as a partner on today's program. I offer special thanks to all of you in our audience today, both here in the room and online. And on your behalf, I thank the Scottish Government and the Russell and Josephine Cott Memorial Charitable Trust for their support, and my team, especially Dawn Miller and John Maca up there, for working so hard to make this groundbreaking symposium happen. We meet to explore a theme: brain health and dementia care, integrating innovations and best practices in Scotland and the USA. Today's will be a meeting of some very powerful minds with input from preeminent blue chip universities and organizations in Chicago and in Scotland. You may be aware that the organization I'm proud to represent, Chicago Scots, is the oldest 501c3 in Illinois. Tomorrow we will celebrate our 180th anniversary. So in 1845, when Chicago was just a small town of 12,000 people, a group of Scots got together and they formed an organization in order to be kind and to care. And 180 years later, this commitment is made manifest just a few miles away from where we gather today at Caledonia Senior Living and Memory Care, a small retirement community nestled peacefully in the forest in North Riverside. At Caledonia, you'll find the Scottish home, which we built over a century ago and added on in the 60s and in the 90s, and also the McLean House model, an innovative model of memory care, which we opened in 2016. with a symposium, as Dr. Kowalczyk said, here at the Christopher Center. In 2023, we were honored to receive the largest philanthropic gift we've ever received, $14 million from the Ngoni Foundation. And this pioneering gift is foundational because it gives us the opportunity and indeed the responsibility to dream of innovatively transforming Caledonia to meet the future needs of seniors in Chicagoland. The great Scottish economist of the Scottish Enlightenment, Adam Smith, once said, "The real tragedy is poverty of imagination and aspiration." So we have an ambitious vision for this region, to work with experts to transform Caledonia into a world-class, world-leading center of excellence in memory care, a place where compassion meets with cutting-edge science, a combination of global expertise and a regional commitment to create something extraordinary. I'm so grateful that today's group of experts have agreed to join us in this journey so that American and Scottish engagement and collaboration is at the very heart of our transformation. Now, today's symposium will feature a diverse group of experts. Their bios are available online and at the QR code on our screen. It is our intention today to bring you some new ideas, some inspirations that you can take back with you to your families and your communities and your work. Today we'll have 3 panel discussions on public policy, advocacy and the law, on the natural, built and social environments, and on lifestyle, culture and care. The panels, which will be conversational rather than formal presentations, will last about 40 minutes each. I'll ask questions of the experts and we'll have a discussion for about 30 minutes and then we'll open up the floor for Q&A for 10 minutes. So please have your questions ready in the room, and if you're joining us online, please use the chat function. Following the panels, we'll have keynote remarks from Scotland's former First Minister, Henry McLeish. But first, as a bookend to Henry's keynote, our first speaker is Dr. Jay Olshansky. He's a professor in public health at the University of Illinois in Chicago. And I'm delighted that Jay has agreed to set the scene for today's symposium as we consider our theme, brain health and dementia care. Jay's work focuses on human and population longevity and aging. He addresses some big questions. Is the human body designed for long-term use? What if we prolong the very thing that most of us fear, old age? And is healthy and productive aging even possible? I know that you'll be fascinated when you hear about his incredible work. So, ladies and gentlemen, please join with me to help us see the big picture. Let's welcome Dr. Jay Olshansky.
All right, can you hear me all right? Speaking of hearing, by the way, in case you're wondering what these things are hearing aids, which I really like wearing. And as it turns out, these are a form of dementia prevention, as I assume all of you know if you're familiar with the relationship between hearing loss and dementia. So it's one of the reasons that I'm wearing them. So I've got an interesting story to tell you, and I only have a few minutes to do it. So let's see how I can do this. I'm going to be focusing on 2 things based on presentations that I've given before. One was a testimony that I gave before Congress about two years ago. Was it 2022, something like that? 3 years ago. And also a manuscript that I published last year in Nature Aging on the implausibility of radical life extension in humans. I'm only going to use 2 slides. So I'm going to keep it really simple, really high level, very straightforward. And if anyone has any questions, I'll be around throughout the course of the meeting. So let me paint the picture for you of what we've done to ourselves in the modern era. This is the transformation that we've done in humans over the last century in terms of raising life expectancy. Life expectancy for humans historically has always been low. It was always below 30 years. And we quite remarkably, within the last century and a quarter, raised life expectancy dramatically up to, depending on where you are in the world, roughly about 80 years today. Now, here's where I want to get a message across that you probably will not be familiar with. But hopefully this will turn a light bulb on for you and you will look at human longevity differently than you have in the past. The tendency in the world of aging is to believe that there's some sort of limit to how long we can live and that that limit is ahead of us and that we haven't gotten there yet. And I'm going to tell you that this particular perspective is fundamentally, foundationally, biologically incorrect. The natural limit to human longevity is decades behind us. We think, my colleagues and I believe, that the natural limit to human longevity, if you remove all medicine, all medical technology, all interventions of any kind, any surgical procedures, we think that the natural duration of life on average for humans would probably be somewhere in the 30 to 50 range, maybe on the higher end of that range. And I will suggest that everyone, almost everyone in this room, is living on what my colleagues and I refer to as manufactured time. Time that has been created for us by medical technology. I'm 71 years old. My life has been saved at least a half a dozen times, probably more, by medical technology. I wouldn't be here, and I can assure you that the vast majority of you in this room would also not be here if not for medical technology. So we're lucky to be able to make it as long as we can in this modern era because of modern medicine. It's been absolutely remarkable. And I've suggested in my Nature paper that last year that we're butting up against this limit. And we have to be careful what we wish for, because if we continue to push out the envelope of survival, we may not like what we see, depending on how that is done. Critically important, we are not moving towards the upper limit to human longevity, we're moving away from it. It's sort of like stretching a rubber band. The more you stretch it, the more difficult it becomes to stretch it further. When it comes to human longevity, once you achieve a life expectancy, and I've argued this in an article I published in Science back in 1990, that once life expectancy for a population makes it to about 85, it's not really going to rise much higher, no matter what we do. Even if you cure major fatal diseases, one thing gets in the way. By the way, just out of curiosity, anybody have any idea what that one thing is that gets in the way of making us immortal? The biological process of aging, which influences all of the main organs in the body. So here's the image that I want to use. This is my last slide, by the way. Here's the image that I want to use. Now, years ago, back in 2018, I was invited by the editors of the Journal of the American Medical Association to convey this message, the one that I'm conveying to you today, to physicians. Because physicians are in the trenches treating patients as they should be, saving lives, allowing us to live as long as we do today. And I needed an image to convey this message of what we've done to ourselves and where we're headed. So I created this image right here. Now, I'm assuming, I'll just assume no one in the audience knows anything about demography, so I'm going to keep it really simple. Imagine 100,000 babies born in a given year. Those 100,000 babies, if you apply to those babies the death rates that exist at all ages in a given year, and you plot out the ages at which those 100,000 babies would die, you would get what's referred to as a distribution of death. That's what this is. This shows you, and the area under the curve is the same, regardless of what time you look at. So that, I think it's a gray line, illustrates, this happens to be the distribution of death for females in the United States in 1900. What do you see? It tells us a really powerful story about what we've done to ourselves. Infant, child, and maternal mortality was one of the main causes of death back in 1900. You can see that, this is for females, so I intentionally put this in here for females, so you can see that bump right around the age of 20, that's maternal mortality. Basically what we've done during the course of the 20th century is we've dramatically reduced early age mortality. Infectious and parasitic diseases have declined dramatically. We got what we wanted. We saved the children. All of us are alive because we've been saved as children, many, many years ago. So we got what we wanted, more than 100 years ago, longer lives. The problem is that we had to pay a price for those longer lives, and that price that we had to pay is the rise of the diseases and disorders associated with aging. So heart disease, cancer, stroke, Alzheimer's, other forms of dementia, hearing loss, vision loss, these are all consequences of living long enough to experience the biological process of aging. It's what we wanted. We wanted these long lives, but we had to pay a price. And the question is, where are we headed now? So I placed this distribution of death within a background which I refer to as the red zone. So the blue line is where we are today. This is what the distribution of death looks like in all long-lived populations today. We shifted the distribution of death from the young to the old. We got what we wanted. We got these long lives. And now we have all these diseases and disorders associated with it. So the question is, what have we done to ourselves? Now, I use this red zone. The red zone is designed to give you a sense of the timing of frailty and disability in a population. When you push populations deeper and deeper into the red zone, we see diseases and disorders associated with aging, including especially Alzheimer's and other forms of dementia. If we continue to push out that blue line by going after one disease at a time, heart disease, cancer, whatever it is, stroke, which I'm not suggesting we shouldn't be doing, by the way, but if we succeed, and I am confident we will succeed in pushing out the envelope of survival and shifting that blue line deeper and deeper into the red zone, we are going to see a rising prevalence of frailty and disability among individuals that make it to older ages in the future. So you're in the right business here, because the prevalence of Alzheimer's and other forms of dementia is going to rise dramatically as a consequence of success, not failure. It's important to realize this is what we want. We're making ourselves live longer. These bodies weren't designed to last. We have lots of things that go wrong with these bodies as we get older. So the price we have to pay are these diseases and disorders like dementia that will rise dramatically. It's one of the reasons, by the way, that my colleagues and I have suggested that we need to focus in not just on the diseases associated with aging, but on the underlying biological process of aging itself. The work of modern medicine is to push out the blue line, which I get it. I mean, look, like I said, my life has been saved multiple times by medical technology. I'm here because of it. What aging science is focused on, it's called geroscience, what aging science is focused on is compressing that red zone, pushing the red zone out so that we could be healthier longer, so that these diseases and disorders, when they occur later or not at all. That's what modern aging science is all about today. By the way, this red zone is really easy for folks to understand in Chicago. I use a football analogy, and I'll end with this, by the way. I'll use a football analogy. If you're a fan of the Chicago Bears, up until this year, if the Bears made it to the 20-yard line, they had almost no chance of scoring a touchdown. It's called the red zone. And the reason is that all of these defenders are in a very compressed part of the football field, so it's hard to move the football. In biology, in human biology and aging science, it's the same thing. It's called competing risks. It's basically a phenomenon where if you push out the envelope of survival, diseases accumulate in aging bodies. And that's where we are today in this modern world, where we have all of these diseases and disorders that have accumulated in these older bodies. So be careful what you wish for. Because life extension without health extension, I would argue, is harmful. And I think that may hopefully set the stage for where you're headed the rest of the morning. And I'm going to stop there and thank you for your attention.
Thank you very much, Jay. I know you made a bet with a colleague that in your lifetime, one of us or some of us in the world would see 150, live to 150. Who's winning that bet?
So the bet was, with a close friend, will anyone alive in the year 2000 be alive in the year 2150? 150-year lifespan. So we won't know who the winner is until 2150. Neither myself nor my colleague will be around. But when you ask who's winning the bet, my colleague will say he's winning because aging science is accelerating rapidly, and I would agree with him that aging science is accelerating rapidly. And I would argue there's no chance it's not going to happen. The difference between 122, which is the observed longest-lived human, Jean Calment from southern France, and 150 is they're light years apart. So, and I'm not sure anyone wants to live to 150 unless they can be healthy the entire time. So, thanks for the question.
Dr. Jay Olshansky, ladies and gentlemen, who came up with a word when we first met online. He mistook my accent for being Irish. And he said, but you work for a Scottish organization. So he said, that makes you Skyrish. So I've used that quite a lot, particularly when the Ireland rugby team was in Chicago. Our first panel will focus on public policy, advocacy, and the law. And why are these concepts important to those of us working in caregiving, both professionally and personally? Although they are core parts of the support system that most of us don't see on a daily basis, we all need them to work. And our three panelists for this session live and breathe policy, advocacy, and the law. They are Delia Gervier, who is Regional Vice President and Executive Director of Alzheimer's Association of Illinois, Brandon Peck, who is a partner at Peck Ritchie LLC, and joining us remotely from Scotland, Jim Pearson is the Deputy Chief Executive of Alzheimer Scotland. Let's welcome them, ladies and gentlemen. Does this microphone work okay? Can you hear me? So let's begin by welcome and thank you for being here, folks. Hi, Jim. How are you?
Good morning.
I'm fine, thank you. Nice to see you all.
How's the weather in Scotland?
Oh, it's the usual grey.
Perfect.
Grey and wet. Yeah.
Well, let's begin by asking Delia and Jim the same question to tell us about the priorities, the work they do in your sister organizations. I'm particularly interested to hear from Delia about Illinois Brain Health Project and from Jim about Brain Health Scotland. And I'm looking for about 3 minutes from each presenter. So Delia, please tell us about your work.
Okay, well, thank you, and good morning, everyone. As Gus mentioned, I'm Delia. I'm the Executive Director for the Illinois chapter of the Alzheimer's Association. I've been with the association for about 13 years now. And our organization is the largest nonprofit funder of research in the world. That's one of the things that is a priority for us. We have grown over the last few years in terms of the advocacy efforts that we have done to help increase funding in research from what used to be about $400,000 in funding for Alzheimer's research at the NIH to today, we are knocking on $4 billion with a B, thanks to the work of the association and partners. And I'm sure you've heard of all of the progress that we've made as a result of, okay, I was hoping. I'm sure you've heard of all the progress we've made in research as a result of those increased dollars. We are actually in an era of treatment, and that hasn't been heard of for over 20 years. So that's really, really exciting. Our association also, as I mentioned, advocates on behalf of people with Alzheimer's disease and their families, and I'll share a little bit more about that later on the panel. And then we reach people through education and support groups. In the state of Illinois last year, through our educational programs, we reached over 47,000 people. And this year we are on track to reach 42,000 people with awareness presentations around brain health, the signs and symptoms, healthy living, et cetera. So that's part of our work.
And Delia, I know that you've led initiatives for culturally responsive education
Yes.
partnerships with
So-
organizations.
Yeah, so statistics show that people in underrepresented communities, so African Americans are twice more likely to develop Alzheimer's disease, and people in the Hispanic community are 1.5 times more likely to develop the disease. So in the state of Illinois, we have enacted conferences in those communities. 2 years ago, we had our first conference on the south side of Chicago, so in a predominantly African American community, where we saw over 200 people come. Those conferences are offered to the community at absolutely no cost, and we convene speakers to present on a variety of topics. We have resources available in the room, vendors for those individuals. This year, we had over 500 people in attendance, and this event will be in April next year. We did this as well in the Hispanic community, a very similar conference, but in this case, it was done entirely in Spanish, translated simultaneously in English for those in the room who were bilingual. And in that particular case, we had over 200 people in attendance. This year, we had to pivot and be virtual because of the current climate in Chicago, but it was still very well attended online. And so we do these because we know that in those communities, they tend not to seek out resources, and they tend to be diagnosed a lot later in the disease process, which what that does is create a double whammy in this case, especially now that we have treatments that are effective in the early stages of the disease. So early stage treatment, but late stage diagnosis, there's still that gap. So the goal with these conferences is to continue to raise awareness in those communities, signs and symptoms, what do you need to do, where to go, how to get diagnosed, et cetera.
Thank you, Delia. And Jim, can I come to you now in Scotland, and could you tell us about the work of Alzheimer Scotland, please?
Thank you, Gus. So I'm Jim Pearson. I'm the Deputy Chief Executive of Alzheimer Scotland. I worked here for just about 26 years. We are Scotland's national dementia charity. We are a voluntary organisation. I'm a bit blown away by the type of resources that Delia mentioned there. Anything that we've got pales into insignificance, but we are the only national charity for dementia within Scotland. Our main aim is to ensure that no one goes through the experience of living with dementia alone, and our priorities are around the prevention of dementia, ensuring that care is of the highest quality and everyone has equality of access to the highest quality of care, and also investment in research and research infrastructure within Scotland to ensure that we work towards potential disease-modifying treatments, even a cure. We are a campaigning organisation. We advocate for change. We influence policy and practice across Scotland. We work in collaboration with a whole range of partners. We also are a service provider, and we provide services through the income that we generate ourselves from fundraised income. But we also are commissioned to deliver services by health and social care partners, public bodies in Scotland, to deliver things like post-diagnostic support for dementia, dementia daycare services, community connection services. Big part of our work, and really important part of our work, is the involvement of people with dementia and carers. And we have two active voice groups, as we call them, the Scottish Dementia Working Group and the National Dementia Carers Action Network, both groups who either are people who have a diagnosis of dementia or family members and carers. They've been working with us for over 20 years now. I think the Scottish Dementia Working Group was, as far as we're aware, perhaps the first of its kind anywhere in the world, giving a voice to people living with dementia. And they're our partners in everything that we do. They are campaigning, activists, they sit at every level of Alzheimer Scotland. They're on our board of trustees in terms of governance of the organisation as well. And everything that we do is informed by them and influenced by them. And we also have a 24-hour, 365-day a year helpline. And that's part of that goal of making sure that we're always here for people with dementia and that they're never alone. You mentioned an interest in our work in brain health. We established several years ago now an entity which sits as part of Alzheimer Scotland called Brain Health Scotland, and that was built on the growing evidence of the potential for reducing or preventing some dementias. So we worked with the Scottish Government, we established Brain Health Scotland, and we established, again, as far as we know, the first brain health clinic in Aberdeen in Scotland in partnership with the Scottish Government and Grampian National Health Service. Our work in brain health follows a model which is essentially about influencing public health, working with public health, raising awareness, education, influencing public health policy, but also targeting populations. We do a lot of outreach, we work with employers, we work with education establishments. We have a schools programme for young children on how to protect their brain health, and we deliver education programmes. What we have done is embedded our brain health work into our brain health and dementia resource centres, and that allows those people who may have a concern about the potential risk of developing dementia to come in, to talk to our expert advisors, to have an assessment to determine what their risk factors may be, and using the 14 modifiable risk factors to develop advice and a personalised plan for them. We obviously know that we can't ever guarantee that no one will get dementia. We do know that if we get this right at a population level, we'll see improvements. And the final part of that is the brain health services, the brain health clinic, where people can collect clinical advice, and also perhaps an earlier disease detection, diagnosis, and the opportunity to participate in research and potentially clinical trials.
Thank you very much, Jim. Impressive work both here in Illinois and in Scotland. Brandon, can I come to you now, and could you tell us about your work with the Illinois Supreme Court's Commission on Elder Law, please?
Absolutely. So again, thank you for having me this morning. The Illinois Supreme Court in 2022 created, most recently, an Elder Law Commission. And they had a few charges or tenets that they wanted to focus on. And I'm just going to go through them briefly. One was, to collect information regarding attempts to defraud seniors in Illinois and make recommendations to the judiciary and associated agencies, so the public guardian, the public administrator, the office of the state guardian, entities who step in when there is no one to help individuals. They wanted to propose and edit Illinois Supreme Court rules on conduct that currently exist. One is referred to as Rule 1.14, which gives attorneys guidance regarding dealing with cognitively impaired clients. This comes up very often in my practice. The overlap between the legal and medical field continues to get, I would say, heavier and more gray every single day. As lawyers, we are tasked with treating our clients and communicating with them as effectively as possible. There are, I would say, somewhat outdated rules on how we should do that, and when we need to bring in medical experts to say, hey, I don't think this individual can follow what's going on anymore, and we need to take affirmative steps. They also said, they want to examine adult guardianship proceedings in the state, make recommendations, analyze and make recommendations for the standardization of guardian ad litem qualifications. So for anyone who's been involved in a court proceeding, There are guardian ad litems for children, and there are guardian ad litems appointed when there are guardianship proceedings. So when there's a lawsuit that alleges that someone is disabled and there are no advance directives for them, so no powers of attorney, living will, something to guide people, and there's this vacancy, and we are seeing who will be the most appropriate candidate, the courts across the state appoint guardian ad litems who are third-party attorneys to go speak and do an investigation. It's essentially supposed to be as if the judge could go out and visit everyone. In Cook County and the surrounding collar counties, it's not going to happen. I don't know how it works in the rest of the state. I assume the same thing. But they're focused on the qualifications of these individuals. And the last two were, to study the programs of other states, compare and contrast, and then work in conjunction with the Illinois Mental Health Task Force regarding recommendations. Do you want me to take a little bit further?
Sure.
Sure, okay. So very briefly, the Illinois Supreme Court has its own set of rules. They have rules on professional conduct. They have rules governing how lawyers are supposed to interact and how they are supposed to conduct themselves with clients and generally in the practice of law. So like I said, one is referred to as Rule 1.4. It's communication with clients. In what we do, we have a lot of people who come in and say, hey, I have just been diagnosed with Alzheimer's or another form of dementia, and I would like to amend my estate plan. And we say, okay, we'll meet with you. Let's see how this conversation goes. 99 out of 100, I'm going to say to them, I need a note from your primary care physician or the neurologist or anyone who you have seen recently, and the state requires an MD, to tell me that you have the capacity to make these documents. And this is to protect them, to protect our conversations, to make sure that they're privileged, and to make sure that we can try to stay out of court if possible. If we don't think that we can do that, we will say, hey, we don't think we can do that. We may need to go into court and have someone appointed for you. The other thing is if we don't think we can represent them, we will let them know and see if there's something we can do. It's never too late to have someone's estate plan put in place. Advance directives are very important to everyone in this room to know who to talk to and whose guidance to follow. The court can facilitate estate planning. They can facilitate powers of attorney and wills. They do it with some hesitancy, but they can do that. The other thing that the Supreme Court really focused on was this qualification education for guardian ad litems across the state of Illinois. And this was pitched in a commission, in the Commission on Elder Law. It didn't make it through the first. We're going to go around. We're going to try to work on it again. But essentially, they wanted qualifications for individuals and some type of training, as opposed to, the judges have a list, quote unquote, of attorneys that they like, that they respect, to go in and meet with these individuals. The biggest impediment that we have faced is Chicago and the collar counties. There are plenty of lawyers. We are not short on lawyers. We got about 45,000 around here. So there's plenty of lawyers, more than some people would like. But as you get to central Illinois and southern Illinois, there are not. A lot of towns have a few lawyers who are general practitioners. They are not experts in this area. And the commission, which is obviously statewide, felt that asking some of these individuals to try to qualify themselves would, in essence, disqualify them from acting as a guardian ad litem, and then you have no one. So we're working on trying to find qualifications that all the courts, including down south, will accept, so that we can have something, uniform across the board to ensure that they are qualified, that the Supreme Court believes they are qualified, that the medical health care individuals feel they are qualified to go out and speak with folks.
Thank you, Brendan. Delia, can I come to you now? Illinois was the first state to mandate insurance coverage for FDA-approved Alzheimer treatments and diagnostic testing. Can you tell me, this is a two-part question, can you tell me why that's important? And then can you also talk about the 2023-2026 Illinois Alzheimer State Plan?
Yes, and that bill just passed in this year's session. And so, yes, Illinois is typically a trendsetter, which I'm really excited to say. This is one of many bills where we are the first state in the country to pass. 2 years ago, we passed a bill that mandated training, dementia training for all healthcare professionals that came in contact with a person with Alzheimer's disease. So it's really critical now that we have FDA-approved drugs that insurance companies are covering the cost. And that particular bill addresses state-funded insurance plans. You may have heard that when those drugs first came out, the cost was hovering around $25,000 to $30,000 a year. And so to be able to have this bill passed now in the state of Illinois now means that we have a template set that other states can replicate, and hopefully across the country we'll see that. Those drugs, the costs are covered by CMS, so Medicaid, Medicare cover those, but now having that as a win is pretty amazing. And then the state plan was enacted several years ago, and it was designed it was enacted through legislature, and it was designed to establish a roadmap for a dementia-capable state of Illinois. And it brings together partners from across the state that provide recommendations on how we can become and continue to be more dementia capable. Over the years, we've also updated the plan to add the Alzheimer's Disease Research Fund, which is a fund that Illinois residents can make a donation through their taxes. They have the ability to opt in a small amount, and those dollars are used to fund a dementia coordinator that is housed at the Illinois Public Health Department. And in collaboration with the Alzheimer's Association, as well as other partners in the state, we provide recommendations every 3 years when we update the state plan on continuing to build the best practices possible in the state for dementia capable. You mentioned earlier, you asked me about the Brain Health Project, and I forgot to mention that. So I have on my phone, I'm really proud of this little, you might not be able to see it online, I'm sorry, but we introduced 2 years ago, can you see this little pink brain? Her name, or his name, is Sarabella. And so through a grant that we received from the Illinois Public Health Department, we are, through this project, we are promoting the modifiable risk factors that Jim mentioned earlier, and promoting brain health. The website that features Sarabella is yourbrainwillthankyou.com. And that particular website is free, and it features all of the modifiable risk factors. It provides resources on how you can implement those risk factors, which are basically a non-pharmaceutical approach to reducing cognitive decline. The association just launched a brain health app, Habit Builder, that is featured on that website. It is a free online tool where you can go in and design your own personal plan on how to implement brain healthy habits. And so I didn't want to not talk about this because I'm really excited. We just launched this app about a month or so ago.
Yourbrainwillthankyou.com.
Yourbrainwillthankyou.com.
Wow, thank you.
Featuring Sarabella.
Jim, I'll come to you now, if I could, with another two-part question. As we talked about Illinois being the first and a plan, Scotland was the country that gave the world's first national guarantee of post-diagnostic support. Could you talk about that? But could you also talk about the 10-year dementia plan that Scotland has in place?
Yeah, absolutely. And I feel like I'm claiming a lot of world firsts here, and should just maybe as a caveat remind everyone that there's a big draw taking place today in the US about the World Cup, and Scotland have just qualified for that for the first time in 20. So we don't we don't come first at everything, and I don't expect we're going to ever win the World Cup. However, yeah, the National Post-Diagnosis Support Guarantee came about as a consequence of Scotland's first national dementia strategy. So Scotland has now had 4 national dementia strategies, 4.5 if we count an interim one that was produced as we came out of the pandemic. But the first one in 2010 identified 2 key actions. And this was informed by consultation across Scotland with people with dementia and their families and carers who were saying two things we really need to see better here: support after a diagnosis, and also improved experience in acute hospital and other hospital settings. So the work around post-diagnosis support came as a commitment to respond to that call. Alzheimer Scotland had some funding from the Scottish Government to trial and do some practice research in a particular area of Scotland, just outside Glasgow, working with people who had just been diagnosed with dementia and their families to determine what did good support, post-diagnosis support look like for them. And that project was called Facing Dementia Together. Those people working with us told us what was really important to them after a diagnosis, and that evolved into what we call our 5-pillar model of post-diagnostic support, which is a framework around delivering a person-centred, person-led approach to support, to help people achieve the outcomes that are important to them, and to work not just with them, but with their families. So that work became the basis of a national guarantee, which was implemented in 2013. So 12 years ago, nearly 13 years ago now, Scotland has had a commitment that everybody who has a diagnosis of dementia is offered a minimum period of 1 year's post-diagnostic support from a named and skilled post-diagnostic support link worker. And that is, without a doubt, been a significant game changer within Scotland. Still a lot of work to be done around ensuring that everybody who has a diagnosis gets access to that, and continuity and equality of access to it. But without a doubt, it's been a significant success. As I said, Scotland has had 4 national dementia strategies now. The most recent one was published in 2023. It's called Everybody's Story. It breaks from tradition from the previous strategies, which were essentially 3-year plans with quite fixed commitments in each of those. This is a 10-year plan. It sets out a much broader vision, and it's delivered through a series of 2-year delivery plans, and we're just coming to the end of the first delivery plan. One of the things I think that's very unique about this, and I mentioned earlier the work we've done around Scottish Dementia Working Group, National Dementia Carers Action Network, people being involved in the development of the strategy, that's always been true. But this time, the Scottish Government actually embedded that in by creating what's called a National Lived Experience Panel. And that Lived Experience Panel brings together people with a diagnosis of dementia and family members and carers who are embedded in every part of the development of the strategy, the delivery mechanisms, and the monitoring of the strategy. And there is a strategy steering group, a delivery group, national delivery group, and some subgroups looking at specific areas of the strategy. And that lived experience panel chairs most of those subgroups, but is embedded in the delivery. That's really important. And I think the Scottish Government deserve to be applauded for that commitment to ensuring that people with dementia are right down the centre of the development and implementation of the strategy. So the strategy, as I say, there's a 10-year plan. It has a broad vision. There are some key deliverables that were set out as part of the first 2-year plan. One was a public-facing campaign to challenge the continuing stigma that's still associated with dementia, co-produced with that National Dementia Lived Experience Panel. Establishing a cross-governmental, cross-sectoral oversight group to support the learning from the work that we were doing around that Aberdeen Brain Health Service that I mentioned earlier, including publishing an independent evaluation of that service, which has been done, establishing a short life working group on looking at workforce learning and the development needs both for now and the future. Previous strategies had implemented what was called the Promoting Excellence Framework, knowledge and skills, and a training framework that set out the knowledge, skills, and very importantly, the behaviours of expected of anyone working with people with dementia. And that was at different levels, from dementia informed, dementia skilled, dementia enhanced, and dementia expert level, depending on the nature of your work with people with dementia.
Thank you. Thanks, Jim.
Yeah, so, sorry.
Thank you very much, Jim. I want to be mindful of our time because we've got some folks in the room to ask some questions. But Brandon, I want to come to you with another two-part question, if I could. You and your father wrote two excellent books, which I commend to everybody in the room and in the online. They're Alzheimer's and the Law and Don't Let Dementia Steal Everything. I wondered if you could tell us what readers would learn from these books, and also, as you look around the world and the country, what represents innovation in elder law?
Sure. So I appreciate that. Gus actually read the two books, so that's fantastic. The first one is more of a resource guide for attorneys or individuals, I would say, whose families have been diagnosed with Alzheimer's or former dementia. The second is a little bit more of a narrative of stories that we have dealt with day in and day out, and kind of the pitfalls and the roadmap to address those. So they're both good. The $12 residuals I get every year is great. Thanks. Covers Starbucks. But the innovations that we have seen recently, I think people are planning more. I think that is a huge thing. I think that medical providers, particularly primary care physicians, neurologists, are letting people know that they need to put plans in place, not to sell lawyers and litigators like myself short, but you want to put a plan in place to stay out of court. What your clients will spend to do that versus what they'll spend to be in court is night and day, and we don't want to do that. It is a time-consuming process. The other thing that I think we've seen is the expansion of a lot of these agencies. So again, I referenced earlier, in Cook County, we have the Office of the Public Guardian, we have the Office of the State Guardian. And unfortunately, these agencies have ballooned in size due to the amount of people that they have to help out. We're referring to individuals who don't have family, friends, or the resources to have a third party step in. So they are trying to spearhead innovation and identifying, problem areas, where they see repeated issues over and over again. And then I think another big innovation that we're seeing that trips into elder law directly is from the financial institution side. Banks these days are much more willing to raise a red flag and stop financial exploitation or freeze someone's accounts if they believe that there is cognitive impairment going on. So I have that case at 11 o'clock. I had that case yesterday at 2 o'clock. It's something we see over and over again. But I think in the past, it was, we were chasing our tail, and now I think in a broader sense, they're trying to stay a little bit ahead of it.
Thank you, Brandon. Now, just before we go to questions, I've got a quick fire for all of the panelists today. If I was to place a magic wand in your hand, what change would you make in the world that you can describe in 30 seconds? So, Delia, I'll come to you first, please.
I thought you said 30 seconds. I thought, oh, wow, I have so much. But what really came to mind right away was financial relief for caregivers. We find that caregivers are burdened financially, and whether it be through some type of subsidy or tax credits, if there is a way that we could relieve our caregivers who are shouldering this burden and the cost of caring for their loved ones, that would be my wand, magical.
Jim, can I come to you? The magic wand is yours.
Yeah, so again, lots and lots of things, but just I should maybe say, and I mentioned a lot of good things that are happening in Scotland, but actually a lot of that is sitting within the landscape of really severe reductions in public spending and cuts in services. So right now, for us, we are campaigning to ensure that the government leads the way in setting real key standards for the guarantees of what people with dementia can expect from diagnosis right through to end of life care to protect services that are often vulnerable when spending is tight. So definitely financial investment, equality of access to high quality supports for people with dementia. And the reality is we don't always have that. So right now, that's what I'd settle for.
Thank you, Jim. And Brandon?
I would go off Jim's comment a little bit. You know, I think the saddest thing that we see that I'd like to see a fix is individuals call with dementia or a form of Alzheimer's and they don't know how to pay for the care, as Delia and Jim said. They have read online they're going to lose their house if they have to go to a nursing home, that they're going to lose all their savings. So the magic wand would be to figure out a path, like Scotland sounds like has done a great job, where we can ensure that the care is going to be covered and people aren't going to lose all their assets paying for it.
Thank you very much, Brandon. Now the floor is yours, ladies and gentlemen. If you have questions for our experts here in the room or online, please do put your questions in the chat, and John over here has a roving microphone that we can get to you. Any questions? Thank you, John.
Hi, my name is Katie Green. I am a Chicago-based therapist. I specialize in dementia. I'm here with Lorenzo's house today. My question is related to guardianship. A lot of times I will get families, and when we talk about advanced care planning, the first thing they say is, someone told me that I have to get guardianship, and that, you know, with this diagnosis, it equals guardianship. And I would love a one-liner, because I know that's not true, because some people can get by with power of attorney. So I would love just some insight, maybe just a couple sentences that I could give to these families saying that's not necessarily true, but we can talk about it more. Any insight there?
And is this for a panelist in particular, or are one of the panelists prepared to answer?
I'm happy to answer.
Yes.
Yeah, I'm happy to answer. So
Right.
it's a great question, and it does come up every single day. And what we deal with is people who say, I don't have anything. Is guardianship the only option? And it's really, can we facilitate an advance directive for you? So again, I'm a lawyer, I'm not a doctor, but in this realm, we're all working hand in hand and trying to do what we can for our clients and patients respectively. So what I tell people is, talk to your primary care physician, neurologist, if you're seeing that individual already. And if they can write a note, hey, 2 lines on their letterhead that, John Smith can execute a power of attorney for property, a power of attorney for healthcare. That works for me, that works for the court, and that will keep them out of guardianship, which I would love to do.
Thank you, Brandon. Any other questions in the room or online? My good pal, Jim Boyle.
It'll be very brief and practical. Very brief and practical. It's for Delia. You mentioned that CMS was in a position to cover costs. I believe it was for training. And I'm curious if you understand that still will exist.
So the costs that I talked about were costs related to the medications and treatments for dementia. So Leqembi and donanemab, those treatments that remove the plaque from the brain. So when I mentioned the cost from insurance companies and CMS, that's what I talked about. And then training, we talked about the bill that was passed several years ago, which is training for healthcare professionals. It provides for a minimum of 1 hour of training, which is not a lot, but there was nothing before for any healthcare professional that came in contact with a person with Alzheimer's had to have at least an hour of dementia training, related training. Does that answer your question? Yes. Okay.
Thank you, Jim. And thank you, Delia. Any other questions from the room or online? John, do we have any online?
Nothing yet.
If not, then I have a question for Jim. In the next panel, we'll look at the impact that environment can have on the lives of seniors. Can you, in the 2 minutes and 40 seconds that remain, talk about the outdoor dementia resource centres in the Highlands and in Edinburgh?
Yeah, so we a couple of years ago established the first dementia outdoor resource centre, which is in a place called Badaguish, which is in the foothills of the Cairngorm Mountains. It's a partnership with the Cairngorm Mountain Authority and also a charity organisation called Paths for All, which is an outdoor space. And that is a resource centre that sits, as I say, it sits in a most beautiful part of the country, and it's a brain health and dementia resource centre. It utilises outdoor spaces and outdoor resources, and promotes the ideas of green health. We recently established another one, which was in Edinburgh. It sits in the grounds of a beautiful castle called Lauriston Castle. We're not short of those in Scotland. We got it for a kind of peppercorn lease. It's the gatehouse of Lauriston Castle. No one told us about the amount of costs that would be involved in refurbishing a 400-odd-year building, right enough. But that is a fabulous resource. Sits in these beautiful gardens and has a memory and sensory garden. And the essence of those is about green health. And we all know the benefits of spending time in green spaces. You're not short of a few of them there where you are yourself. So those have been fabulous success, really well received, and using sensory, using outdoor spaces, using planting flowers, education around nature, environment, and bringing some of that indoors in the colder days. Has been absolutely fabulous. So yeah, really well received, and great partnerships there with these outdoor other partner organisations.
Thank you very much, Jim. And ladies and gentlemen, let's thank our panelists, Delia, Brandon.
Thank you.
Thank you, Brandon.
Thank you.
Dr. Olshansky has said that few people throughout history have had the opportunity to experience productive aging. A healthy older life can and should be nurtured. So let's consider how the world around us can shape health and longevity. What impact does connection to environment, especially the built, natural, social and cultural environment, have on the lives of seniors? We've designed this conversation to explore this question on multiple levels and from multiple perspectives. And my hope is that each of you will come away with a new insight or inspiration from today's panel. I'm really excited to get the conversation started, and our experts are Raj Shah, who is a professor in the Department of Family and Preventative Medicine, Alzheimer's Disease Centre at Rush Medical College, David Victorson, who's a professor in Medical Social Sciences and a director of the Flourishing in Society and Health Research Lab at Northwestern University's Feinberg School of Medicine, and Leslie Palmer, who is professor of Aging and Dementia Design at the University of Stirling in Scotland, which is, of course, and I say this without a word of bias as an alum, by far the world's best university. Let's welcome them, ladies and gentlemen. Leslie, sorry, could you tell us about how you came to focus on memory care and architecture?
Yes, thank you. Well, thank you very much for the opportunity to come to Chicago for the first time. Thank you, Gus. So I am an architect by profession and a practicing architect and professor within ageing and dementia design. And my practice over the past 20 years has always had a focus on centering the voices of people who are marginalized by design or excluded from the design process into the design process. And that manifests within the architectural practice with a focus on economically low-income communities within Scotland. And then within my research role, I work within a kind of novel and interdisciplinary field called neuroarchitecture. And that's an area that specialises in looking at how the built environment is perceived and experienced by individuals, but also how the built environment affects our ability to feel, to have emotional responses, and to orientate particularly. So I'm the academic lead of the Dementia Services Development Centre. We were formed in 1989, and our founder, Professor Mary Marshall, was the first person to publicise dementia design friendly principles in the 1990s. And this came at the time when, even within the UK, we had not yet introduced statutory codes for supporting people with physical impairments. We were already looking at how to support people with cognitive impairments there too. And so the field that I work within, dementia design, is now internationally recognised as a non-pharmacological approach to ameliorate the symptoms of design, and it crosses built environment, products, and the natural environment as well.
Thank you very much, Leslie. I'm going to encourage all of the panelists, if you have a response or if you'd like to add to anything that one of the other experts have said, please chime in. Raj, having thoroughly enjoyed and appreciated your insightful remarks that you made in this room 9 years ago when we hosted the symposium to open our McLean House, I really wanted to thank you for being here again today. Could you tell us about your work, please?
Sure. Thank you, Gus, and thanks to the audience here in person and online. It's great to be back in River Forest. In some ways, my medical career started here. I trained at West Suburban Family Medicine Residency Program, and our clinic was here in River Forest, where I learned how to take care of patients and families, and then went to Rush to do my geriatrics fellowship. And I've been at Rush now as a professor in family and preventive medicine and at the Rush Alzheimer's Disease Center for the last 25 years. My day job is mainly to try to think through how we can evaluate and design interventions to help people in various stages, from prevention to early diagnosis to treatment of common conditions in aging, especially Alzheimer's disease and related dementias. But that also, has an entire community that has to be surrounded for us to work together as researchers with patients, with families, to learn new things. And we've learned a lot over the last 25 years. I think the other aspect is that building that community becomes really important to supporting learning and co-learning together. And that allows us to be part of the community and to share information we are learning and to learn from them. And then to train another generation of individuals from various professions to be involved in the care of people with living with dementia, supporting their caregivers, and people at risk. And I know at some point we'll talk about some of the other work we've been doing that makes me excited to be back in River Forest as one of the dementia-friendly communities in the state of Illinois. And hopefully to see us advance more avenues of supporting people with dementia through those type of community building efforts that have been going on. But thank you for having me here today.
Thank you, Raj. And David, welcome. It's great to meet you in person, having thoroughly enjoyed our conversations on Zoom. Could you tell us about your focus on health and nature?
Absolutely. It's a real honor to be here today. I'm at Northwestern University, where I am a professor of medical social sciences. I'm a psychologist by training, and a lot of the research work that I do is at the intersection between physical, mental, and cognitive health. Much of my research is, over the last 20 years, focused on cognitive neuroscience, particularly on the role of things like mindfulness meditation in health and how it can not only affect how we see the world, but it can get under the skin and affect our bodily systems and functions and processes as well. An extension of that work has, over the last decade, been on the environment around us and what can happen with our health and with our communities when we spend more quality, safe, meaningful time in nature, green space, everything from living near green space or nearby nature to purposefully engaging in natural environments, whether it's a walk through a park or a forest preserve, or spending multiple days and nights in nature in some different setting, camping or hiking or doing other things. And there's been an abundance of really well-designed studies showing, as I think James mentioned, that the obvious, that's been known since the beginning of humans on this earth, that when we've spent the majority of our evolutionary history with nature, only until recently in the history have we really purposefully tried to separate ourselves from it. But how good it is for us. And there are theories for why this is. And we're starting to also, our Western research and medical approaches are starting to catch up with that indigenous wisdom of how important being in and around nature is for our health and well-being. And actually part of my research now is how good it is for Mother Earth itself. And how we, by being in nature, we can return the favor, we can practice reciprocity, and actually do things that are really good for the health of the planet.
Thank you, David. Let's spend some time talking about the natural built and social environments. And I'll come to you first, Raj, if I could. Could you talk to us about how important, I'm going to ask about those dementia-friendly communities that you've been working with as the second part of the question. But could you talk to us about what social environment and culture in particular, how does that impact and matter to care? And then if you would talk about the dementia-friendly communities.
Yeah, I mean, I think in general, as somebody who practiced and see people individually or, in clinics as they came in for evaluations for their cognitive difficulties with their families for many years. I was the medical director of the Rush Memory Clinic. We would always try to think about them in isolation, about they're here coming into our space in the clinic, getting evaluated in a slightly foreign environment, and we're trying to figure out, actually what are they doing in their real lives so that we can make a diagnosis of dementia. And what I found is that there's so many other aspects you have to understand that you can't always get in that kind of artificial setting. One of the things I learned in training in family medicine was the home visit was like the most wonderful thing you could ever do, right? Because sitting with somebody in their kitchen to go through this stressful evaluation and this question, you could not only pick up signals about what that person was saying, but you could actually physically see it around you, right? So it ties into the environmental exposures telling us and giving us signals about how a person's doing and how they're interacting. But then it goes even further into sort of the ideas of what we build in our minds and socially around the ideas of culture and the things we're brought up with, our understanding of changes with aging, what's expected, what's not expected, how we should respond as families and engage, and when do we seek help? When do we think about this not as a normal process of aging, but as something that's, a condition that's affecting the health of our brain? And every culture has defined different ways about approaching that pathway. Some are more tendency to go and seek help early, to realize it's something that's not necessarily something that has to happen with aging. And other cultures have embedded that change as part of the aging process and a way to handle that. And so you have to kind of understand sometimes, a little bit all these other circles around a person to help to evaluate where they're at, especially in the diagnosis phase, and then how you're going to manage them in the future to help them, because it's a mix of our technological answers, but also there's so much we do with the cultural perspective, and caregivers play such a huge role. And if the caregivers feel supported, they make a big difference in how people do over time, and what I've noticed in my experiences. So we have a lot to work, and there's no one culture that's going to tell us this is the way it is, right? These cultures are built in very different ways, and as practitioners, you have to kind of understand that. The flip side, which is to get to some of the things around dementia friendly, and the reason behind it, and why I think it's an important area, is that as much as we need to know the culture to make a diagnosis, understanding culture, understanding community, understanding the broader dynamics even across from family helps us to develop a better treatment plan to support people as they go through these experiences. The movement for Dementia Friendly USA started with a grant from the Target Foundation in Minnesota, probably about 20 years ago, where they took a public health approach to trying to reduce the stigma people feel as people living with dementia and their families and becoming isolated from their communities. So the entire idea was to develop sort of a multi-sectoral approach in a community, usually a town, a vicinity, community defined by place, where the work would be to get together not only the medical providers, but the social service providers, the frontline responders, the police officers, the firefighters that would have to sometimes address calls that would come in, businesses that were local in that environment, librarians, all the people that make up our community, to think about the person with dementia as the center point that live in their community, and to work together to think about how we can reduce stigma and isolation. So they spread out this kind of model in Minnesota. We were watching in Illinois. What we have in Illinois are state of Illinois regional Alzheimer's disease assist programs. There's 3 in the state of Illinois: Rush, Northwestern, and Southern Illinois University. And in about 2010, we started thinking like, well, what can we do together to really help families with our knowledge and knowledge of others in this space to work together to reduce barriers so we can improve the lives. And we were looking at this model that was happening in Minnesota. And we were thinking, like, how could we do this? And then what happened is that got presented in 2012 at the White House Council on Aging. And they launched this national effort to create states that would become dementia-friendly and communities within those states. And we were ready because we had already started working together, that we applied to be the technical lead for that. And in 2015, the Illinois Cognitive Resources Network, which is not a not-for-profit, it's just people wanting to do the right things and getting together and organizing themselves with very little funds, right, to just get things together so we could have a structure, share information. And we applied to be the state technical lead for the state of Illinois. I'm the faculty administrative support for that activity. And when we started, we got that in 2015, we were like hoping we could get like one community in each of the planning service areas in the state of Illinois to be recognized in that process of planning, to do those first steps to become a dementia-friendly community, to show their commitment to working and helping individuals in their community along. There's about 16 planning service areas in Illinois, so we were looking for like 16 communities in 5 years, all right? We have 50. Right? What happened is that people just understood this was an important thing to do, and some of the first individuals who started the process made it better. And then what started happening, which is really curious, is once they had a little bit of a structure and they knew a pathway, and they could see some of those early communities do the effort, they said, if River Forest can put together and become recognized as dementia-friendly, why can't Oak Park do the same thing? And so that friendly competition between, communities came into play, and that feeling that they could lift up together, and I think that's what started accelerating some of these activities. I have a call out, and I told Gus this, it's great that they've been a community resource in North Riverside for so many years, right? But I would really love for them to take the lead as one of their first projects to make North Riverside a dementia-friendly community. I think they can do it, right?
We'll do it.
Okay.
Thank you very much. And I'll look to my colleagues who are here, Erin and Vicky and Barb and Nikki, who is manager of our McLean House. We'll get on that, guys. That intentionality, Raj, is admirable and encouraging. And I turn to Leslie now. Could you talk about how intentionally designed spaces can impact and affect our understanding of well-being and caregiving?
Yeah. Intentionally designed spaces is a term I'm going to steal from you, Gus. I haven't heard that before, but I like it. For me, intentional design is evidence-based design. And I should say that as an academic architect, but I'll give you some examples of what evidence-based design would be. Within the context of dementia design, if we have a client who has Alzheimer's type dementia, it will typically present in the early stages with wayfinding difficulties. And therefore, when we're working with that client, the sequence of spaces is really important to reduce the demands on processing of going through a number of different spaces and having to plan ahead. And that can impact on our urban design. It can also impact on the home design. If we're working with a client who has Lewy bodies dementia, they're more likely to experience hallucination. And so reflective surfaces become problematic. That could be a mirror during the day, or that could be a glass window in the evening. So that reflection can create some agitation, some hallucinations. So it will vary depending on the subtype of dementia. And then if we're working with somebody with a rarer form, for example, of PCA, they present their first presentations will be their visual processing difficulties. And so we have to really understand the subtype and how the environment can respond to them. And that's where evidence is important. And dementia-friendly design principles are an overarching series of principles around support care for the carers, around individuals, their identity, their agency. But really, when we get down to the nitty-gritty, it's about understanding the end user. And in many ways, not seeing the dementia, but just in any other case of design, who's your end user and who's your client in that sense. And so architecture, again, my discipline bias here, but architecture for me is a discipline which is entirely human-centric, and it's quite visionary. We have to see a situation that doesn't currently exist. And it's also quite optimistic. Very few architects will design a space in the hope to hurt somebody. But we do have an architecture of fear and control, and we can deploy those tools to intimidate, to exacerbate certain conditions. And I think that one of the key aspects of dementia-friendly design is recognizing that as designers and as commissioners of design, we are quite often self-referential. Ethnographers who have studied architects recognize that. We all refer back to our own experiences when we're trying to inform a design brief. And we all default to our own design preferences as well. And so a core part of dementia-friendly design is referring to the evidence base. There are scientific basics, principles to beauty. We have the Fibonacci sequence, we've got the golden rule. There are very similar scientific bases to good quality architecture.
Thank you very much, Leslie. I want to now come to you, David, and stay on the theme of intentionality, if we could. In a day, in an era where we're all so kind of defined and consumed by the screens in front of us, how important is it to be intentional and to prioritize our engagement with nature?
Yeah, that's at the crux of much of the evangelizing that I do with my research, is that our brains by design like to access the default mode network, which is the part of our brain that likes to drift into daydreaming and not focusing. And it's a nice screensaver for us to be able to do that. There are times and moments, though, where we don't necessarily want to daydream our way through important moments. For me, I still have this pivotal moment when I was reading to my child, he's probably 3 or 4 years of age, and I was reading words in a children's storybook to him, but I was not in that story with him. I was thinking about the buzz in my pocket from my phone and wondering who was emailing me. And it was right around that time that I thought, man, I really want to be here with my son reading this story. And we have these kinds of moments all the time while we're doing normal activities of daily living, eating, in conversation with colleagues. They're supposed to be some of the important moments of what bring meaning to our lives, yet we can daydream our ways through them. And so intentionality is a health behavior. It is no different than getting enough sleep, walking enough steps, drinking enough water, and it's modifiable. So nature, I study mindfulness. A lot of people have a hard time carving out 10 minutes, 5 minutes, even 3 minutes to try and sit and settle and notice. And that's okay. What I found with nature is that, man, it is full of things. It is one of our best intentionality teachers. When we're in safe, meaningful nature. Now, I'm not talking about, because of course there are harms in nature as well, whether it's a grizzly bear if you're in Montana, or a hurricane, or some other natural disaster. But when you're purposefully spending time, whether it's in your backyard in a hammock, or walking through a forest preserve, and you're turning off the podcast, you might ask the person you're walking with if we could just walk for a minute and listen to birdsong, or just notice all of the things around us. That engages different parts of our brain that help us reset our fight, flight, or freeze response. So that in and of itself reduces cognitive load. And then it opens up other areas of our attentional frame to allow us to experience pleasant emotions and even awe from the simplest of things, from a bug or the way a spider web has been created, things we walk by without awareness all the time. And so usually when I'm evangelizing, sometimes people can feel a little threatened, like they're being bad, that they're not doing this, and that is not the intent at all. It's that our brains are wired to daydream. Let's keep daydreaming, but let's give ourselves a few chances a day to tune in with intentionality to our surrounding environments, because that is big medicine that we're just letting go by.
Thank you, David. The recently departed Chicago artist Tony Fitzpatrick, I watched a video of Tony taking a slice of bread out to a bird feeder in the morning outside his house. And he looked at the camera and said, for the price of a slice of bread, you can hear God sing. Mm-hmm. These birds started to sing. It was incredible. Let's talk about how the social, natural, and designed environments come together, and with the intersection of those environments. Leslie, I stole something from you as well. I don't know whether you know, but yesterday Leslie came to visit Caledonia, and we were talking about options for the development of our campus, and you said the answer's in the architecture. So I'm stealing that from you, if that's okay. But you've said that design is transferable, but care as part of culture is not. Could you talk more about that, please?
Yes, sure. So it's perhaps about whether it can be exported. I do a lot of work internationally. I advise on projects in Japan, Australia, the Nordic countries. And a lot of the evidence base which underpins dementia-friendly design was developed in Occidental cultures. And so there's a big question around, can you export it and deploy it internationally in other cultures? And if you are interested in the longer version of this, there's a couple of articles within ADI's 2020 Dementia Report that myself and my colleague wrote on this. But globalization has created homogeneity in design, which could be seen as success. Starbucks here looks like Starbucks in Tokyo, looks like Starbucks in Aberdeen. So that's an example of that kind of globalized design homogeneity. But design needs to be rooted in site-specific context. It needs to respond to vernacular, and it needs to respond to the users. And so what I have found is that you can export elements of design. And I'll give you an example. Bright light therapy, where you are not able to get access to outside spaces. And I'll take your point, David, if we've moved away from our ancestors and being external. A result of that is sleep dysfunction. And over 50% of people with Alzheimer's will have some form of sleep dysfunction, and they may not realize that that's one of the symptoms. Over 90% within Lewy bodies. and poor sleep and dementia is bidirectional. And if you're in an environment where you're not able to get access to the outside space, we can support better sleep quality and duration through artificial lighting, being exposed to a certain wavelength at a certain length of time, at a certain point in the day, to a certain level of illuminance. There's a lot of research in this area. I can transfer that to Japan because that illuminance level is a controlled environmental specification. But when we did our first project within Tokyo, it was in the suburbs, and it was a fairly large development of family apartments, retirement living, and then adjoining that was a dementia care development. And then there was a kindergarten, and there was also long-term care and step-up and step-down care. And we worked remotely for the first 2 years on the design, providing guidance via online calls. And a lot of my team were really looking into the culture and the understanding of the importance of things, for example, as bathing within Japanese context and the use of gold within certain environments. And we really thought that we understood how to respond to that specific cultural need. And we completed this lovely project with the architects and the design team there. And when we went to visit it, it looked fantastic. We had deployed the evidence from, as I say, Occidental cultures into this care environment. And fantastic, won lots of awards. And then when we went back the year later to assess this, it became quite apparent that the carers within that space, the formal paid carers, had changed the furniture. They had changed the environment. And I felt really that I had let them down. And I also really wanted to inquire as to where had the design intent and their requirements, where was the conflict? And what became apparent, it was in the interpretation of person-centred care. They said, yeah, we deliver person-centred care, very much like yourselves. We follow a Kitwood model, very similar to the UK. But in reality, it was very different. And they had, in my view, a much more medicalised approach to it. And they were advocates of supervision. And in the principles that we deploy, we have passive observation. And there's a difference there. And the main difference architecturally was the nursery station. And we don't advocate for nursery stations. They tend to be focus points. They tend to increase agitation. There tends to be a lot of activity, increased risk of falls in that area. And we advocate for passive observation through staff moving through spaces, through a principle called total visual access, so clear lines of sight, and so on. And when we worked with the teams there, they had moved filing cabinets and tables into the centre of what was supposed to be the heart of the home. So it would be the equivalent of the dining table in McLean House became an administrative table with files and so on. So the dining table no longer read like a dining table. It was no longer legible as a space to eat. It looked like a space to be observed. It was medicalised, and that had a negative impact on the residents, and the space wasn't used. And so when we went back for the second project, we worked with the same client, same care provider, and what was done differently there were two things. They recruited fresh, they trained fresh, and they trained the staff on principles of person-centred care that married with the design. And we augmented our design approach to support also the cultural nuance of how care was provided. And then when the building opened, my team and I went out and we provided design training using the space. So why is this door this colour? Why is this line created? So we were able to train in situ. And from that, we saw a much better response in terms of that synchronisation of design and care. So I don't think care is easily exportable. I think there really has to be a much more culturally nuanced understanding of the environments that you're working in. And very conscious within the UK context, it just looks like colonialism. Again, we're back in deploying our understanding in a very arrogant way of how other people should live and be cared for.
Thank you, Leslie. David, what lessons from your work with True North Treks can be applied to the design of spaces for people living with memory loss?
In addition to my university job, I started a nonprofit in 2008 to take young adults, teens, caregivers with cancer out into natural spaces where they can reconnect with nature, reconnect with other people who've walked a similar experience, and then reconnect with themselves through the meditation and yoga things that I study. And we take people to big nature. We take groups out into the backcountry of Montana, Wyoming, Utah, similar maybe to what James was talking about in that mountain retreat area. I don't know if James is there anymore, but and one of the first I will say that's not necessary. It's very appeasing for people to get away and to be surrounded and not have to deal with many of the distractions and noise of modernity in a city or an urban center, but you can still do this in a backyard. So just as a caveat to that. But we have found that going away, even temporarily, it can create a holding environment that can support so many other amazing things to happen. There's a British psychoanalyst, Winnicott, who is known for his work with mothers back, I think it was in the 40s or 50s, where he said, there's a good enough mother who just can provide a holding environment for her child, and it doesn't have to be perfect, but it just can be good enough and holding. And that metaphor extended then into the therapeutic environment. So in psychotherapy, we often talk about creating a container or a holding environment for our patients so that they can breathe and be themselves and be authentic with us. And I would say to extend it to nature, it also can serve in a similar way. It can hold us and allow us again to just let go of so many of the distractions and the cognitive load that we carry. And the theories about why we understand nature to be effective. I mean, sure, there's air pollution and noise pollution, and there are actual particles in the air, but there's also the fact that restorative environments can help us completely shift our attention to a soft fascination and to, again, to allow us to access other areas of the brain that calm our nervous system and keep us, again, from ruminating and, not being present. So I guess to answer your question, Gus, what lessons from True North Treks is if we can try to think, and I'd love to hear Leslie's ideas on this, if we can think about how we can bring the holding environment of nature into architectural design. And as you were talking, I was thinking architecture as medicine is I feel like what you do. And you also talked to me earlier about the importance of community in all of that. But how can we bring nature both through a courtyard or a walking path, but also inside the building so that it's a living building with views or other aspects of nature that we know can be helpful. How can that be done with how we're doing dementia and Alzheimer's care today? It doesn't have to just be for Leslie, but Raj too. But since you're the architectural expert,
Am I meant to answer?
Go ahead.
I said you weren't allowed to ask me anything.
I know.
I don't think my PI insurance would like me to say that it was architecture with medicine. Just one of the best typologies when designing for passive observation within dementia care is the courtyard environment, because you create an internal courtyard, automatically provides passive observation, single bank corridors, daylight into the corridors, and so on. And if it's wide enough, then you get the beauty of the outside space framed by the built environment. But I don't have the answers to it, because I'm entirely frustrated whenever I go into long-term care environments, because to get outside, I quite often require a passcode. And this is even when I go in as an auditor to assess those spaces. And one of the key principles is direct access from the principal living areas, unobtrusive, to get into the outside space. And accessible access to outside space is not a level threshold, it's the actual ability at any point to leave the building. And in practice, we've designed for a lot of mental health charities, and threshold is something that we talk about a lot. The ability to break out of the building at really tense moments can drop people's aggression, agitation, really drop the situation. And it's very challenging to do that when you have, quite likely, concerns about the risk of the individual. And if you have staff that are concerned about people going outside, they won't go outside. And if you have staff concerned about their residents, the residents will pick up on that. So drop all of the users' anxiety. Courtyards work beautifully for that. And then if you have more than one story, it becomes even more challenging. I don't know if that answers your question. I think there's a research agenda coming through from this panel. Thanks, Gus. Yeah.
I'm going to ask anyone in the audience who has a question in just a second. In fact, in 90 seconds, I'm going to reclaim that magic wand and ask in 30 seconds, you have a chance to change the world. Raj, I'll come to you first.
Yeah, I mean, I think if there's a lot of things to do, but the one thing I was hoping is that the challenge of the behavioral changes with dementia as it progresses are so huge, and we're not making as much progress as I had hoped, and it's not going to be a medication. Part of it's going to be Medicaid, but it's not going to be the full picture. The suffering it causes is something, if we can keep working on, to think about these other approaches that tie in our environmental exposures with our outside environments, inside environments, and community together to help us to figure out better ways to handle the behavioral changes that go on with the condition, and to reduce some of that suffering and that back and forth that has to go on with people having to go to the emergency room, not having hospitalization spaces, not having enough geriatric psychiatrists, and then getting stuck in a system that can't solve their problems. So that's going to be a challenge, but I wish we can clear that challenge and make it a little bit easier for people that have dementia and their families living with it in their communities.
Thank you, Raj. David, the wand is yours.
Man, I thought of so many things with that magic wand. I assume that it's not just make everything better, but actually if I could make a change that's real, it would be, there's a really good leadership book called What Got You Here Won't Get You There. And the whole purpose of the book is about not resting on one's laurels and reimagining and reinventing ourselves, not changing our mission entirely, but knowing that we need to continually be reinventing. And I think about the growing urbanization across the globe and the decreasing green space across the globe, and how just here in Chicago, we're a great example of how certain communities of color have been redlined from nature, historically. And I feel like we're at the precipice of a really great opportunity to reinvent how we are designing cities and implementing them. And if I had the magic wand, it would be to not just see Chicago as a great, beautiful city, but to also think about ways that we can continue to bring green spaces in and out, especially for those communities who are unfortunately most affected by their separation from it.
Thank you, David. Leslie?
Yes. Bear with me while I explain my justification afterwards, but I wish that each of us could experience what it's like to have dementia for one afternoon. To experience that stress, to experience sometimes the indignity, the visual processing challenges and the hearing challenges. And I say that because, as I mentioned earlier, as designers and commissioners of designers, we're self-referential. And there's a lot of paternalism as well that comes through in some of our approach to design for dementia. And what we know is that if people can experience firsthand the challenges of the people they're designing for or commissioning buildings for, the design outcome improves. And that couldn't be more beautifully shown than with Ford, car manufacturer. I don't know if you know, but they introduced the third age suit when they were designing their suits, which is it's deployed to give their designers the experience of what it's like to drive with age-related impairment. And the outcome of that are cars that have been specifically designed to support people to drive for longer in their life. And for me, that goes beyond design. That's about maintaining someone's independence. It's about maintaining their identity and their joy of driving. And without that designed in empathy, the final outcome would not be as fit for purpose and as considerate. So it's really empathy through experiencing firsthand what our clients might experience.
Thank you, Leslie. I would commend, I know Bill Lowe is in the room. My good friend Bill Lowe was involved with a group called Embodied Labs, and I would commend their work to you. They use VR to embody what it's like to live with dementia. They're terrific work. Any questions or anything from the room or in the chat room John. Lindsay, a member of our Board of Governors.
Thank you. I would love to hear from Raj about, if there's the 50 planning areas in Illinois, do you have a sense of the distribution around disinvested communities, specifically communities of color? And I can think of, West Garfield, in such close proximity to where we are now that I'd love to hear.
Yeah, no, that's a great question and something that we always struggle with as you're building these options. Usually the first responders are the most connected, engaged communities, right, that have the resources, have been working in this space. But one of the things we intentionally try to do is that whoever was the first or whoever were first responders and had the systems in place, we really encourage them to look who their neighbors were. So this happened with River Forest, Oak Park, and Austin. So River Forest started, they got it first. Oak Park was close behind because they've been in competition with each other forever. But then when we presented to Oak Park about their process, and River Forest was there also, we said, you've got Austin right next to you. Make sure you transfer some of that information to the community that's sitting right next to you that might not have these resources. And they did. Austin did it its own way, with its own sort of resources, but you can do this. And that's what it's been the most remarkable thing is like how people have been sharing in our monthly meetings to just transfer information for a common good. We have towns in the middle of Illinois that have like 500 residents that have become dementia friendly. And then we have like places like Austin that have 300,000 residents sitting right there trying to become dementia friendly. They're taking the first steps. Are they perfect at it? Absolutely not. Right? But they're taking those first steps to make their world a little bit better for the people there. And what I end up saying usually is, if you can figure this out for people with dementia, to like put them at front and center with their caregivers, and everything in a community is starting to help to think through what is that feeling like of that person going through that community. You figure it out for dementia, you figure it out for autism, you figure it out for every other condition. You just got to start somewhere. And it's really been encouraging to see how people have been helping. And I hope that people, wherever community you live, whatever little influence you have, like try to see if you go to our website, ilbrainhealth.org, look up the dementia-friendly community, see if your community is there. If it's not, figure out like what you can do. And it might be the first step is just to become a dementia friend, like a personal commitment, 10 minutes of watching videos online, 30 minutes, to just say, I'm going to take the first step. And then build on that. And that's how we build communities, right? People working together with very little effort, but a lot of them doing small things in the right way and kind of pushing it forward, that we get better over time.
Thank you, Raj. I think we've got time for one more question, if there's one in the room or online. Anna, another member of our board.
And just online, there's discussion about clearing clutter as a must, as well as some of the virtual reality tools that Gus mentioned. So it's good chatter online.
I just really want to address Dr. Shah. You mentioned about behavioral, and we haven't gotten as far as we have. Something that really hasn't come up is the whole issue around paid caregivers and availability of staff, and yes, education, but also just sort of the infrastructure of support for caregivers so that they can be in a relationship with people living with dementia in a way that supports their strengths and their emotional health versus maybe being pushed into behaviorally responding. I know that's really specific, but I think the whole caregiver part of it and paid caregiver availability is so huge that you can't really leave it out of the conversations. I know that wasn't a question, it was a statement, sorry.
No, but I think it's a great statement, and it's something that every place is struggling with, right? Like if you look at the Alzheimer's Association, they create a facts and figures report, and they do it for every state. When you really calculate the amount, like for each person that has dementia in Illinois, we think it's about like 220,000 people of our 12 million have dementia right now. There's at least 6 caregivers in multiple generations taking care of them, all right? Informal caregivers, right? And the amount they add in value, right, to keep those people at home at their own detriment of their health sometimes, right? To be that family, we cannot replace by paid caregivers. There's just no way, right? The problem we have, which is so difficult right now, is that we don't value caregivers, paid or unpaid, right? So, and I don't know if that's going to change in our society, right? So the paid caregivers I really worry about is most of them are dual caregivers, right? They earn minimum wage in most cases, and they're not only caring for people that are other people's family members, but they're usually caring for their own family members. And so they get the double jeopardy of having to take both of those things. And we've been talking about this, and the state of Illinois has an executive order out right now with Governor Pritzker to develop a 10-year multi-sector aging plan, and they're about to release it, called Engaging Illinois. I've been part of that committee and their work on the community side. But one of the things is, how do we invest in caregivers at different levels? Not only in training and capacity and understanding that role, but how do we help their lives get better and feel supported and feel less stressed and stigmatized? And it's going to take all of us to work in that space, because eventually we're all going to be caregivers.
Yeah. Thank you, Raj. Ladies and gentlemen, we're going to have a 5-minute break, but before we do, I'm going to encourage everyone to come back in 5 minutes, because we're going to show a video, which is a poem. Now, we all know how important music, nature, poetry, art can be to brain health. And at Caledonia, we have a poet in residence. He started the Alzheimer's Poetry Project. He uses poetry to help residents at Caledonia and elsewhere access hidden memories through call and response poetry. And for today, he wrote a poem with the residents of Caledonia about brain health. And I encourage you all to come back to see that in 5 minutes. Join with me, if you would now, though, to thank Leslie and Raj.
So, my nephew, that's her, I'm going to be on the radar. It's going to your biochem class. Like, I don't know about books. She's supposed to be maybe you don't want me. Because not only they got the books, they I don't know. I'm like, what do you mean? Because you're making me nervous that you're my future. She said, well, it lays out just as a short. And then we're like, okay, let's see if you're correct or not. He said, I love it. And I'm like, and it's like, I'm of course writing in person. Right? Like, I don't understand the difference between like this generation. Yeah, I'm over here. So I do this mentoring in the city. And one of the and she saw, and I never felt so she looked at me and she said, yeah.
So I'm so glad that the world shifted.
Well, yeah, my kids miss it too.
I'm a dinosaur.
And there's
USC.
Yeah. 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 No.
And I'm like, I'm going to
So now you know what we kind of like to make pregnancy, right? Yeah, it's like, no, it is crazy. So anyway, but my, my biggest thing is that this is always totally, the president could be here, with the greeting, I'm like, certainly, and I'm like, I usually say it's the most independent thing, because I always You're bad. 14 as well, so 14 and 18. Yeah, and then are you really? So let's maybe after the year, when I come here, just have a lunch, come to campus. We'll host you for lunch, meet with the college business and talk about what's possible. I think Don Bradford would be the perfect person for you to and I think that's true. And he was
and I'd love to talk with so is it a business school where like you get finance and separate it out?
Well, it's a really, no, it's yeah, so it's a really professional business school, but the dean is an economist. And she comes out of a liberal arts background, so.
Good, good, because the school is all
Also lecturing. Oh, yeah, no, yeah, so some of the advocates from the she sees herself as a scientist, right? And then it changes the I mean, talk about that. She runs the free enterprise center. So it's very, she's focused about so I think there's a lot of
so our work
Testing for sound.
Ladies and gentlemen, if we could all take our seats, we can begin the next session. Thank you. Oh, ladies and gentlemen, if we could take our seats, we can begin the next session. Thank you very much. As I mentioned, we'll start with the poem on brain health that was written by the residents of Caledonia Senior Living with Gary Gleisner, founder of the Alzheimer's Poetry Project.
I said, you're exercising your brain the more things that you do, it causes your brain to work more to remember and hold the memories in your head.
Well, I always thought it was the most sensitive part of the body. And I didn't like to think about something if anything happened to it.
I thought that it sometimes plays tricks with what it's giving me to think about. But I don't want to think about what it says. Think about.
Brain is a white clumps of that size, maybe. White stuff. I learned that in art school. I had to learn human body.
Yeah.
And they showed the brain. And then when someone said brain, I said, this thing about brain. Yeah.
We say to the brain.
We say to the brain.
Thank you.
Thank you
for making me smart.
for making me smart.
From the brain,
From the brain,
we get wisdom.
we get wisdom.
We learn something new every day.
We learn something new every day.
We say to the brain,
Say to the brain,
thank you.
thank you.
Gary is a great blues harmonica player, and we had a meeting with our auditor, our CFO, Don Miller, our VP of Philanthropy, and I, to talk about something very technical and financial. We needed to change some procedure, and so we were all in this kind of business mode. And Gary said, before we begin, and he's pulled out his harmonica and started to play this blues tune, which totally disrupted what we were about to do, but it made our time following that much more productive, because it was almost like an appetizer that cleansed the brain before we began. So I commend blues harmonica to you whenever you can get it. I hope you enjoyed your brain healthy food and beverages. The poem that we heard kind of demonstrates how important poetry, music, and art, and all of the aspects of culture and identity are all important components of health and care. And the next panel I'm really excited about, because our experts bring quite different experience and expertise to the discussion. They've all spent time, significant time in the field, and have unique perspectives on brain health and the future of care. And it is the future that I would like everyone to think about in this conversation. What are best practices and policies that you'd like to see as the prevalence of dementia continues to grow? Our experts in this panel are joining us online: Dr. Paul Cox from Brain Chemistry Labs, Tessa Garcia McEwen, licensed social worker at the Memory Center at the University of Chicago Medicine, and from right here at Concordia, Lisa Peters-Boomer, who is Director of Operations at the Center of Gerontology and Executive Director of the COT Gerontology Scholars Program. And I want to pause just for a moment to thank Lisa. When we called the centre to ask if they would join us again at this symposium. Lisa was very quick to say yes. We're incredibly fortunate to have her as a colleague, a collaborator, and an expert in the field. And Lisa, to you and all your colleagues and students here at Concordia who came together to make today happen, we thank you. Hello, Paul.
Pleasure to be with you this morning.
We're going to split this discussion into two parts. We're going to split it into what is today and what could or should be in the future. I'll start with our host today, Lisa. Could you give us an overview of your work at the Centre for Gerontology and the COT Gerontology Scholars Programme?
Thank you, Gus.
Are we on?
Okay. Well, thank you, and I'm just so excited to see so many faces here in the audience. I know folks are online with us, and I'm really, really honored to be part of this. The Center for Gerontology at Concordia was founded back in 2014 by our colleague Lydia Manning, who's here in the audience, Lydia. And I'm really thankful for all of her foundational work that we're building on. So the Center for Gerontology has 4 focus areas. One is really focusing on bridging academics and our applied work at the center, and really pulling together our interdisciplinary work. We're also moving forward with age-friendly university and age-inclusive higher education projects right now as well. We also do service-based practice and policy shaping work, including work with congregations around spirituality and aging and helping them engage their older congregants in a more meaningful way. And lots of intergenerational work with the community. We're very external facing, and we provide programming to really bring people together and have meaningful discussions, and then doing some evaluation and applied research and translation at national conferences and so on.
Thank you for having us today, Lisa. We really appreciate it.
Thank you.
Paul, can I come to you now? And could you tell us a little bit about brain chemistry labs and the breakthrough work that you did in Guam and Okinawa, and what that has taught us about how lifestyle can impact brain health?
Sure, I'm an ethnobotanist. Brain Chemistry Labs is a not-for-profit organization in Jackson Hole, Wyoming. We began by going to the villages that have the highest rate of Alzheimer's in the world, which was in Guam. 2 villages where at its peak, 25% of the adults were dying of these diseases. We discovered that their food was tainted with a bacterial neurotoxin called BMAA. We replicated that symptoms in animal models, in vitro models, and now we're engaged in a FDA-approved phase 2 trial at Houston Methodist. I wanted to find places that were very different from this but had similar environment, and that took us to Okinawa. So, Gus, is it okay if I show a few slides? Is that okay?
Yes, please. Thank you.
Okay, great. So we started working in Okinawa on the very northern tip in a little village called Ogimi. Okinawa became only fairly recently in history a part of Japan in the 1860s. They all learn Japanese in school, but they have their own language. Well, this little village has a language separate from the rest of Okinawa. Ogimi is known as Longevity Village throughout Japan. It's a matriarchal society, and there's nobody that's been raised in that village that is known to have Alzheimer's. People routinely live well over 100 years. I've spent a lot of time there interviewing the villagers. They're extraordinary people. It's almost like a time machine to sit with somebody who's 106 years old and hear them tell you about their earliest childhood. In fact, if I could take your participants there with me, it just might change their view of aging. So we got extremely interested in what's going on here, and I've come up with a few sort of learnings that I've received from these remarkable men and women on the village, and I've sort of captured that in what I call Create Your Own Blue Zone. Every month we send out a newsletter to supporters. So let me just go through this very quickly. How to create your own blue zone. Blue zones, of course, being places where people live for a very long time and don't have neurological illnesses. So one thing that's come up is get better sleep at night. It's completely dark in Ogimi. Has also come up at our clinical trial at Houston Methodist is that people that get good sleep, don't have sleep apnea, have a much lower rate of mild cognitive impairment, which is a precursor to Alzheimer's. The Ogimi women get up every day and exercise. They dance, they sing. It's remarkable. And there's many studies showing that even something as short as a 30-minute walk each day reduces risk of Alzheimer's disease. Something that I'm sort of very interested in is all the people there have their own little gardens. They tend plants. Of course, gardening is the biggest vocation in the UK, including in Scotland, Gus, and there just might be something to that. They're very socially engaged. The villagers get together about once every 9 or 10 days. And they, in the morning, they have little dances and they little sort of games like Peter Rabbit. I can't keep up with them. They're amazing. Also, statistically, it's shown that learning a new language or even attempting to learn a new language reduces risk of Alzheimer's disease. I asked Andy Weil, who visited me in Jackson Hole, why this might be so. He said, well, maybe if you can't conjugate the verb in English, you just go to Spanish or whatever. But that again is a statistically significant finding. Building a cognitive reserve to sort of always be learning seems to also to be a real reduction in terms of Alzheimer's. Oliver Sacks, who was my mentor in sort of remedial neurology, felt very strongly from his clinical experience that listening to music reduces the risk of Alzheimer's disease. And of course, here in Jackson Hole, even though we're in a remote part of Wyoming, we have a wonderful symphony. Listening to great music, music that lifts your soul. Maybe that's like listening to poetry from Robert Byrne. And then one of the most established factors in reducing Alzheimer's risk is to adopt a Mediterranean diet. These women and men in Ogimi eat a diet that's based on 25 species of seaweed. They eat a lot of tofu, very little red meat, occasionally bonito. They avoid shellfish. The Mediterranean diet, rich in fruits and vegetables and olive oil, has repeatedly been shown to reduce risk of Alzheimer's disease. So here's our website, brainchemistrylabs.org, and we'd be happy to share with anybody this newsletter. But we're very focused on their diet at Houston Methodist. We're looking at an amino acid called L-serine. It's one of the dietary amino acids. They get about 4 to 5 times the amount in their diet as we do in ours. And so that's what we're testing in a randomized placebo-controlled trial at Houston Methodist for 100 patients under the leadership of Gustavo Roman.
Thank you, Paul. Thank you very much. Tessa, I'll come to you now if I could. Could you tell us about the important work that you do? And I'd also like you to talk about how you support families as they navigate through the tough dynamics that can challenge them as they begin to live with memory loss.
Yes, thank you. I really want to give you all a clinical perspective on the ground of what happens in directly interacting with the patients and the families. So I have been working at the Memory Center at the Chicago Medicine under the leadership of Dr. James Mastriani for the last 9 years, and just walking alongside their journey from pre-diagnosis onward and care navigating all the different twists and turns that we know it happens. And one day we had a patient named Lorenzo who was very young, and quickly we became a place where we were very interested in young onset dementia as well, because his son, was like, what about us? And he said, you know, what can we do? Where are the resources? And so his wife, Diana, built a nonprofit called Lorenzo's House that has now grown to all 50 states in over 32 countries in the last 5 years, supporting the children, the youth, and the young adults in virtual spaces. Oh, thank you. And so, walking alongside the patients and the families every day, here's what I'm learning. The patient often feels unseen, misinterpreted, embarrassed, and especially lonely, whether they are at home or in residential care. I once asked a man who was a leader in his community, what would you like to have more of these days? And through his tears, he just put his hand up to his head like a phone. And he said, I just want to call. I just want to visit someone to do that with me. But I want them to do it not because I have dementia, but because they want to be with me. And that's key, with me. And that's the heart and soul of it all, helping the family, the caregivers, the staff, and everyone to feel moved to connect with the person inside who had a former life, had dreams and goals, a previous profession, likes and dislikes, and has trauma histories. So what does that look like? It's meeting a sculptor who has severe depression, exacerbating memory loss, who has his collection dusting in the basement, and connecting him with a companion who can help him curate an art showcase and find purpose again. It's just yesterday, a woman who couldn't sit still at home and learned that she loved photos, and she used to own a hair salon. And so I told the daughter to set up stations of hair models and photo albums all around the house so that she can do hair wherever she is and look at her photos along the way. It's having a sign hanging for the person with frontotemporal dementia, explaining their behaviors that define their likes and dislikes and triggers according to their 5 senses, because words are hard to come by. It's knowing their former career, putting that on the sign, communicating how to best approach them when they're stressed, because behavior is communication. So we want to teach the families how to notice their unique style of stress. And it's also about getting as many people on board. So what Gus is talking about is the complex family dynamics. This is my favorite part. So I gather the whole family in the room or a Zoom, and I say, hey, this is a serious brain condition. If it were cancer, everyone would hop to it, you know, without hesitation. But this too is an all hands on deck diagnosis. I understand that every one of you has a different relationship and history with mom, so I invite you to participate or not in a way that works for you. So, are you the faraway one? Okay, call regularly and pitch in for some costs. Are you close by? You can help with the care. You don't quite get along? Then call in a few meals for delivery. So what I'm finding that this happens when we do this, it opens up the opportunity to get more family involved, when often it's usually just the one. And it also gives a chance to those who have lost connection to reconnect, because they're recognizing this is serious and this is a declining condition. And finally, what's also incredibly impactful is helping the staff and the family members understand that the memory glitches are unpredictable and completely beyond their control. It's happening to them. Therefore, you can imagine how much it feels to be so unsettling and terrifying. And it means that like they genuinely can't communicate. So when they say, hey, I'm scared, or when they say, no, that means I can't, or I don't know how. And because by and large, in most dementias, they remember how you make them feel, I encourage these two types of people. I encourage the ones who say, oh, I miss being a daughter. I just want to date my spouse again because they're so burdened as a caregiver, or the ones who have the toughest histories, to curate as many memories and moments as possible so that they can begin to associate positively that you are the one who makes them feel good. And that right there, I witnessed this firsthand, regularly has the power and potential to repair a cold history or to reconnect the weakened bonds from being a caregiver. So I always encourage, revisit those 5 senses and have that favorite ice cream or watch that favorite movie, and they may remember you as the one that gave them a good time.
Thank you, Tessa. That leads on to something that Lisa, I heard you say several times in our conversations, that we must honor individual personhood. Could you talk to us about what you meant by that?
Absolutely. This is a word that I think we probably stole from the disability community in the first place. They were steps ahead of the aging field in some of the advocacy that they have done. So honoring a person's personhood and even extending that to adulthood really is, it also is reinforced in Kitwood's work. I know in previous speakers mentioned Kitwood. It's about honoring an individual by creating meaningful, purposeful opportunities for them to engage, right? To look at a person and see what they can do and what they can offer. It's also about dignity of risk, right? How can people, how do you honor someone's personhood by allowing them to make decisions, even if it might be a little risky? It's also about reciprocity, whether they're in your home, whether they're in the community, whether it's adult day services or residential. Where are some opportunities for people to have reciprocity and to really think about purposefulness, right? Not just keeping people busy, not just engaging them in something that's always observational, but really how can they continue to engage in the life of their home, of their program, of their community. And it's the little things. Are we making sure that if they're involved in art making, that they're using adult materials? If we're doing art looking, are we looking at, I hate to say real art because art is obviously subjective, but are we looking at art that is created in a way that really honors adulthood? Are we, we talk about end of life, and how are we honoring people's personhood as their life comes to a close? And I know we have here Tiffany and Lydia also from Wally's Hearth, which is a new social care and community-based model that really brings people together to honor people's preferences and personhood. So, that's just the tip of the iceberg when it comes to personhood and giving people time to finish their sentences, not rushing them to make a decision. Not just taking a social history when someone comes to a new program, but utilizing that to make sure their surroundings reflect them. And Tessa, some of the things you said were so important. And how do you provide that meaningful interaction in a way that's sustainable? And people's tastes change. Their preferences change, and they're also able to learn new things. Even if we don't think so, they are. So how can we provide those opportunities? So that, again, that's just a little taste of it, but I think it's at every level, the community level, the care level, lifestyle, how can we bring people together around these concepts? Because that's kind of the golden nugget, right?
Yeah. Thank you, Lisa. But Paul, you mentioned on our call many of the things that Tessa and Lisa have just covered. You mentioned observing these in Okinawa and other cultures. How important are these things like religion and identity and and social interaction, how impactful have you seen them be on the brain?
Well, certainly in the case of Ogimi Village, they're incredibly social, and it's just woven into their daily activity. The other point, coming off what Lisa was saying, is that in many of the indigenous cultures I work in as an ethnobotanist, age is seen as a benefit. They're the librarians. So in a little village I was in Samoa, they were hit by a terrible typhoon. People had to actually lay flat on the ground so they didn't loft into the air. And the oldest person in the village said, I remember a cave. And this all went back through all the people. He remembers a cave. He crawled, got him into a lava tube. She had a whole village of over 300 people inside a lava tube for a 3-day hurricane. It saved their lives. So I think there's a certain prestige and dignity that's accorded to people who are older. And in my own practice, this translates into interrogating people's long-term memories, particularly if their dementia form is Alzheimer's disease, because they may not can remember my name, but they certainly can remember their tennis coach at McGill University where they lived. And singing is another issue, is when they can sing Cole Porter, they know all the words to all the songs. So
that was
and they yeah.
Sorry, Paul. The point you make is something I hear and see at Caledonia a lot. And we had a resident who sadly passed away, but before she was nonverbal largely, except if she heard the words, "We sleek it, Curin Timorous Beastie," and she'd finish a Robert Burns poem like that because it was there in her memory. And Gary Glazner had the same experience with his mother. He walked into the room and his mother was living with dementia, and he's a very flamboyant poet, and said, "I shot an arrow into the air," and she looked up and said, "It came to land, I know not where." And that's how he begun this journey that he's on. It's incredible what these things can unlock in our minds. And I'll tell one more story before I then ask you to look into the future. Member of our board went back to Scotland to visit his mother who was living with dementia. And when he walked into the room, he had that kind of heartbreaking moment where she said, "You look just like a wee boy I used to know." And he said, in that moment, I knew that she may not remember me, but I must remember her. And I think that's what we're saying here. Now, let's look into the future. Let's look at what could or should be. Could you talk about any gaps in our understanding or our training, access to care, or innovations or ideas that you hope to see in the future? Tessa, I'll start with you first. Could you talk about that?
So yes, there's gaps in understanding, there's gaps in training, there's gaps in care, and how can we imagine a future center for excellence in memory care? One of the things in the gaps in understanding is that oftentimes we are super reactive when we are handling tough moments in dementia. And one of the most powerful things I've learned from one of our support spaces for a care partner, the spouse goes, "I think I figured it out." She goes, "I'm learning to respond not with why, with exclamation points, because your body language, your tone, everything is alarming, but I'm learning to respond with, why, with a question mark, because then you have a moment to really respond with calm and dignity." The gap in training that I see is that I notice a trend that happens all too often where patients are booted from memory care for a behavior and sent to Jerry Psych, and then they're no longer welcome back, and the family cannot take them home. Where do they go? One example was a language barrier, Jehovah's Witness, who reacted because a nurse came in with a needle and he couldn't communicate in English and tried to defend himself. So we need staff training to combat the prevalence of patients getting misinterpreted or labeled and permanently documented as combative and aggressive during a genuine moment of maybe a fear or a cry for help, and they get blacklisted for placement in the future, and it's devastating to the family. Another issue is the gap in access to care, especially for the young onset population. So the Social Security Administration wisely and thankfully has recognized 10+ dementia diagnoses to be eligible for disability income approval on the compassionate allowance list at any age, keyword, any age. So yes, they get their income, but what's the grave oversight? Younger onset families suddenly become single income or both no longer work because they don't qualify for the subsidized care because they were working and they're not qualified for Medicaid. So they have to stay home to provide care, no income. And then supportive living with memory care, those are the affordable versions of assisted living that's subsidized. It's federal legislation that they must be 65 or older, no questions asked. And then guess what? The supportive livings for age 22 to 64, only physical impairment is allowed, no cognitive impairment. They're completely locked out. So with permission, I am advocating actively for one of my patients who is very sweet and 62 years old, living alone. We just saw him the other day, and he cannot be alone anymore. He's unsafe, and he's too ambulatory and for skilled nursing. And his sister calls in desperation. She has stage 4 cancer. There's nowhere for him to go. She's the one who cooks for him and monitors him from afar with her cameras. So we are speaking up on this on a local, state, and federal level, and we're really trying to change the policies here. And finally, in how we can imagine a future center for excellence in memory care, I imagine not only this type of excellent staff training on person-centered care, like Lisa says, but it would also be equipped with grief counselors on site that can support both the sense of the multiple types of losses that occur in the dementia journey while they're still here for each of the family members and the patient and the staff, because they experience loss constantly when the residents pass away. So.
Thank you. Thanks, Tessa. I agree. Paul, can I come to you and ask you to talk about what you would like to see in the future? And I was struck by our conversation and your comments on Lewy body dementia.
Yeah, what we found in Guam, in these 2 villages where 25% of the people are dying of dementia, is that the symptoms are really spectral. In other words, and I asked Oliver Sacks that, why in the villages do we see these people who are, I mean, yes, they maybe have inability to form short-term memories as in Alzheimer's, but they also have features of frontotemporal dementia, or sometimes we see multiple comorbidities. He said, don't be so sure, Paul, that isn't true in North America. So what I look forward to, I guess, in the future, we've developed microRNA markers now. We're in the process of that give us a really early insight into what's going on in the brain. And I think what I really hope is that we can see a way of showing individuals in transition. For example, dealing with Lewy body dementia, what, 5 million Americans have it, although it seems to be very underdiagnosed. I find that speaking with them about their hallucinations, and maybe I've stepped upon there, but listening to them about the animals they see, listening to them and discussing that with them gives some comfort. So there's the other issue with people with frontotemporal dementia is they really lack the ability to make decisions, and helping guide them through what they do first in the morning can really help. So I guess what I hope for the future is a more individualistic positioning for each patient of what the form of their symptomology is, and then having good folks like my other fellow panelists here guiding the rest of us on how to best language and how best interact with those patients.
Thank you, Paul. Lisa, you've had such a varied career in public health and in caregiving yourself. What gaps would you like to see filled, and what does the future look like through your eyes?
Well, first I'd like to clone Tessa, because I think just having many, many Tessas in our world would be a great solution. You know, from a public health perspective, we always talk about defragmenting the healthcare system, and I think that's kind of a rote response. But what does that really look like? And one of the things that has come up a lot lately in the age-friendly world is the age-friendly ecosystem, right? And I know they're doing a lot in Minnesota with that as well. And how can we talk about not just a dementia-friendly ecosystem, not just a dementia-capable ecosystem, but how about a paradigm where it's sort of dementia-competent, dementia-inclusive? You know, when you don't have to have a special viewing of a movie just to include people with dementia, and that people understand that words matter, that language matters, that the way we talk about and to people influences the way that they are perceived and viewed, that, you know, the slowing down a little bit maybe and trying to understand that that behavior matters too, right? And that's certainly with the not people who can no longer verbalize, but it's also among people with, you know, just early stages of dementia and as they progress, that how can we have a system built around people, and as Dr. Raj said, you know, like it's a concentric circle, right? Like it's built around, it's person-centric, not system-centric, right? Yeah. And I think that's what we've been hearing throughout the day is how can we move to this paradigm where, you know, sort of the grassroots solutions that work in neighborhoods and the sort of academic evidence-based programs, and we've seen some of them scale up in caregiver, evidence-based caregiver supports and that kind of thing. Like how can we bridge these? How can we make sure that when someone, that what we assume around 20% of people with dementia live alone. So how are we supporting people living alone with dementia? And making sure that that people that might manage the apartment they live in, the apartment building, might be able to identify and facilitate their needs, and if their needs increase. So I'm talking about, it's not just a continuum of care that goes from a caregiver and an individual needing support to adult day service, to what may turn into residential and end of life. It's really looking at communities and transportation and the built environment and all of the things, as Leslie said, that sort of envision the system that doesn't exist. And yes, we're a few decades behind in trying to put all these pieces together and support the people who are aging now. But I believe that if we put all of our heads together, if we put all of our energy together, and we look at individuals as individuals who are worthwhile, who can, I mean, we don't think about the fact that people with dementia contribute to our communities, go to the store, they're paying taxes. You know, they contribute in so many ways. And how can we make sure that that continues throughout their lifespan, and that they have the supports that they need? It's a tall order, but I think we can get there.
Thank you, Lisa. We have 5 minutes on the clock, and so I'm going to go to the quick fire question again. And Paul, you may not have been online earlier, but I've been playing a fairy godfather all morning, and giving everyone a magic wand to make a change that they can describe in 30 seconds happen in the world. So I'll come to you first if I could, Paul. The magic wand is yours to make that change.
For Western societies, would be getting more accurate and rapid diagnosis. Again, microRNA markers seem to be functioning asymptomatically before there's, when the prodromal period is starting. So if we could actually have a way of diagnosing who's at risk and who's not already on the disease path before symptoms appear, we could begin treatment and prepare to help them in a better way.
Thank you very much, Paul. Tessa?
Wow, we all have the same magic wand answers because it's such a problem, right? My first one was awareness as well, like having the symptoms properly identified and acknowledged as seriously as cancer or considered for diagnostic workup and proper treatment. So many families come to me saying, Tessa, you're the first person to believe me. After years of going through it, they think it's psychiatric or mental health, or a marital issue. They're sending them to a couples therapist or asking them to go to a divorce lawyer. And there's serious safety concerns, often involving children, that are often dismissed. And so, secondly, the need for global awareness for funds for care at home, for placement and memory care. It's paramount and is a profoundly limited resource because it is $40 an hour at home. It is $7,000 to $12,000 a month in care communities, and the majority of us can't afford that. And finally, inclusion for young onset dementia, because just to really be acknowledged across all settings, because we need age-appropriate activities and entertainment in the adult day centers, in the residential communities, and that legislation that accepts them in supportive living facilities. And I have a dream that all residential spaces in memory care all around the world can have at least 2 neighboring spots reserved for younger patients so they feel a sense of dignity, belonging, and community.
Thank you, Tessa. And Lisa?
So my wand is more conceptual or theoretical. I really think it's the bridging of compassion and strategy with the clinical and academic work, and really kindness.
Ladies and gentlemen, is any questions in the room for our panelists, for Paul, Tessa, or Lisa, or any online, John?
Not online right now.
Jim Bell, member of our board, Falkirk Bairn himself.
So, as someone who entered their 80s this year, and whose brain maybe hasn't quite turned to mush yet, although my wife may disagree with that, I had a question for Paul from Brain Chemistry, related to your observations in the Japanese village. So I kind of jotted down the 10 things that you said that they had, that were behavioral trait patterns that you had noticed. And I look at some of these, and some of these I'm involved in, and some not. Is there, so I've entered this red zone that we talked about earlier today. For the long-livedness of the Japanese who have engaged in these behaviors all of their lives, that's one thing. For those of us who may want to make lifestyle changes now, is there a point in which there's no point in doing that? What came before is going to determine what happens afterwards, or to start to engage in these 10 things even later in life. Does it make a difference?
Thank you. That's a terrific question. And I would defer back to the experience of Oliver Sacks. And you can see a portrayal of this in the film Awakenings, in which Oliver was portrayed by Robin Williams. What Oliver found with people that had dementia from equine encephalitis is that even though they couldn't walk, they could dance. Even though they couldn't speak, they're aphasic, they could sing. And it's fascinating me to see, and Gus, I think you've added a new thing to the table here, which is poetry. And I found this too, that people of the generation who were educated in school in the 1930s, 1940s, learned to recite poetry, to declaim it. And I want to add that to my list, if I have your permission, Gus, is because same thing in Japan, they say these haikus. So I think, yeah, so there's no too late of a stage to try this. I mean, building a cognitive reserve, learning a new language, these are things, listening to great music that anyone can begin in their 80s or even their 90s. And I'm going to add Gus's reciting poetry there too. I want to throw that in, and maybe we can even come up with a clinical trial Who knows? Robert Byrne is a therapeutic for dementia.
There you go. Thank you, Paul. Please do add that to the list. I'd say, I'll quote the Kerr family. Their motto, the Kerr family clan motto is late but in earnest. So I think that applies here. Do we have any other questions in the room? Up at the back, yes.
Thank you. Hi. I think from hearing the panel today, a lot of the problems, like we've mentioned, stem from lack of awareness. So either from the general public, from primary care doctors, from social workers who don't work with, the Alzheimer's or younger onset Alzheimer's. And as a member of Lorenzo's House, which is the organization that Tess is a part of as well, they really empower us to tell our stories. And that's kind of how we raise awareness, by telling everybody about it. Just wanted to hear your thoughts on what else can we do to bring awareness, or who else should we be engaging in these conversations to make the change that we want to see?
And is that a question for all the panelists or one in particular? Okay. Does anyone want to take a stab?
Well, I can take a stab at it. And I think it really needs to be sort of a multi-pronged approach. I think the key is talking about it from the time people are young, incorporating it in school-age curriculum, and helping people connect in their neighborhoods and communities and understand that, it's difficult, but those little moments of joy, the coming together as a community, as a neighborhood, and being a good neighbor, and being able to recognize when someone has dementia, and sort of champion those people and the families to get what they need. But I think it really, it starts when people are young, so that they can be aware, but they can also be part of the solution.
Thank you, Lisa. I think we have about 30 seconds before, oh no, it stopped. 37 seconds.
So briefly, in my past life, I worked in marketing communications, and I can't unsee that we just need a huge campaign. We need beautiful snippets and short commercials on TV like everyone else does for cancer and heart disease and stroke, and everyone else is represented. So if we can show that, and maybe get one into the Super Bowl too, I think we can break stigma when we use media and social media.
Paul, any final thoughts before I adjourn?
Yes, Sanjay Gupta did a documentary on our work on CNN, which you can get on YouTube. Just Google my name and Alzheimer's. His view is that the last person to get Alzheimer's is alive today. I remember as a little boy going to the hospital, seeing people in iron lungs because of polio. I think the work is moving so rapidly that I agree with him. I think we will see in our lifetimes the end of Alzheimer's disease. And so I actually am very optimistic that new understandings, new progress, and particularly new ways of caregiving is going to usher in a really bright future. And so I'm just honored to be with my fellow panelists, and thank you very much for allowing me to participate.
Thank you, Paul. On behalf of everyone in the room, I thank our panelists. Ladies and gentlemen, thanks for spending your morning with us today. It's been an incredible opportunity to slow down and to really think about the bigger picture. Thank you, Dr. Olshansky. The bigger picture related to brain health and dementia care, and some inspiring change makers are in the room today. Each of us in the room deals with challenges related to brain health in different ways. Caregivers, academics, politicians, family, friends, we're all impacted by dementia. And on a day like this, it's so apparent that we're all connected.
by a shared interest in making the lives of those who live with dementia better. Today, we explored this interest all the way from big picture, society at large, environments, through individual caregiving. And I think we can all agree that there are challenges at every level. And so I call for us all to come together to deal with the global rise of dementia. I spoke earlier about the major investment that Chicago Scots will make in Caledonia. We're determined that our investment will have resonance and impact beyond our campus through partners in the field, in the US and in Scotland. And I'm hopeful that today marks a significant beginning of a Scottish-US dialogue, an exchange of ideas, innovations and best practices that we will all own and be part of together. Scotland is a world leader in brain health and memory care. And we in the Midwest and we in Scotland have much to gain from a strategic partnership across the pond. To strengthen this connection, it is now my distinct pleasure to introduce Henry McLeish. Henry is the former First Minister of Scotland and Ambassador of Alzheimer Scotland. At 23, he joined the Scottish Labour Party and chaired Young Socialists. He served in Tony Blair's shadow cabinet from 1994 to 1997, becoming Minister of State for Scotland after the Labour Party's victory in 1997. Motivated by his father's experience with dementia, Henry worked hard to bring dementia support to the national level in Scotland. Following his tenure as First Minister from 2000 to 2001, Henry has chaired the Alzheimer Scotland Fair Dementia Care Commission, working to ensure fair access to dementia services and to integrate dementia care more fully into health and social policy. It is through his diverse experiences, which also include one time the Scottish Broadcasting Commission, the National Mining Museum of Scotland, and as a professional footballer, that Henry has been able to find the right ways to amplify the need for dementia support and to also lead real structural change in Scotland. Ladies and gentlemen, please join with me and welcome the Right Honourable Henry McLeish.
Well, thanks very much. I'm very pleased, very privileged, and very proud indeed to be in Chicago, dealing with an issue of enormous importance wherever you are in the world. And what I'd like to try and do is to talk about humanity, about happiness, about hope, because I'm in awe of the contributions that have been made from panelists today, but I'm also in awe of the fact that people here are making an enormous contribution to the ideas to tackle dementia and whatever form they emerge. And the important thing for me is that, because I'm an ex-politician, I've been in public service now for 55 years, I've been in elected politics for 30 years, anything I say carries a health warning. You might not want to believe me, but you're going to have to listen to me anyway. So what I wanted to try and illustrate, first of all, was I've heard so many people talk, and I'm convinced now that dementia, neurodegenerative diseases in themselves are not given sufficient political priority in the West. It may be in other countries, the amount of dementia that we have doesn't warrant an assault. So in support of all of you, I just believe that in the world we live in, a bigger priority for dementia will mean a quicker access to a cure, which I believe we will have, but it may be 10, 20 years away. And that will allow all of you to do your jobs, because you're doing brilliantly just now, but in an environment where politicians, and I say that for Scotland as well, because we have many good things happening in Scotland, but there is an issue. And it might surprise you to know that you have a very different health system in the UK, insurance-based, and that's the way Americans want it. And you probably think that in the United Kingdom, we have a national health service which is free at the point of need, but it doesn't include dementia. Now, when I first got involved with Alzheimer Scotland, I thought to myself, how ridiculous. So before I left the Scottish Parliament in 2001, we started to put into place free personal care at the point of need. So we are now one of the very few countries in the world that in terms of free personal care, at home, it is free, but nothing else is. So tomorrow, if I find I've got a cancer, from that point, everything free at the point of need. Hospitalization, treatment, all of it. If tomorrow I find a diagnosis with dementia, hard lines. Now, to me, politically and personally, that's a gross insult to the kind of work that you're attempting day in, day out. Now, I'm not au fait with every aspect of the health service in America or the system of healthcare in America, but certainly in Scotland it surprised me, as in the United Kingdom, that we don't particularly have that. And I'm thinking to myself, well, look, how can we raise the profile? How can we make things more important? And then I remember COVID-19. How quickly did we get a vaccine? With miraculous speed. And why was that? Globally, we came together. Big pharma and smaller pharma got together. And politicians realized the importance of getting that. And hey presto, we got a vaccine. So I don't want to be ultra cynical with you, but it seems to me that we have a very gifted planet of people like yourselves. We have vast sums of money. And sorry, that sounds a bit socialistic. Forgive me for that in Trump's America. But the point is, we have the wherewithal. We can make this a lot better for you to be practicing. And in my view, money shouldn't be a problem in a very, very rich world. So to try and capture this idea, I heard a really bad advert or advertising for trying to raise money for dementia in the United Kingdom. I've used the phrase United Kingdom, so you'll know where this is coming from. And the advert said this: with dementia, you don't just die once, you die again and again and again. How outrageously awful. That advertising campaign has been withdrawn. And then I thought, though, what is the other side of this? And a book published in 2009, don't agree with everything in the book, but the front cover says, the opposite to that view is, I'm still here. I'm still here. With all the qualities that I may still have. Because we don't know entirely what, in terms of the brain, is blacked out or diminished by Alzheimer's, various forms of neurodegenerative diseases. But it seemed to me, it made me quite proud to be on this planet, to think that every soul deserves a hearing, and that I'm still here is a message to all of us and to me to say, people matter. And then it was in sharp contrast to that particular advert, which talks about dying every day in front of you. So philosophically, I think the work that's been done is remarkable. Secondly, it needs to be a bigger political priority. Third, it'll flow from that more finance in relation to what you do. But what I'm also interested in is that, and it sounds ridiculous for an audience like yourselves, but when we talked about brain health in Scotland, most of the academics and the technocrats and whatever were saying, well, it's brain health and we can be quite polite and it's quite complicated, etc. Of course it's complicated. You know, for the ordinary citizen, it was a major breakthrough because they had been brought up on a diet of thinking that the brain wasn't part of the body. People didn't talk about brain health because A, it was taboo, A, it was for people who were very clever in these matters, but most people out there in the real world thought, hey, I never thought about that. The brain is the same as my liver, my stomach, my replacement knee joint from my days in soccer. And all of a sudden, it starts to provide a context for looking at dementia, but in a much more positive way. So with that, Scotland is pioneering ahead with what you've heard in terms of brain health clinics. And if you look at dementia from the point of view that, first, there will be a cure, I have no doubt. Secondly, we're looking at care, and a lot of care can be enormously enhanced by more investment. But the other issue for me, which seems to suggest that we need more work, is the common point has been made by many speakers today of just treating people like human beings. When you're told you have dementia, or there's a diagnosis that's positive, it shouldn't be a sentence. It should be a passport towards care and humanity. And you know, the word, if I ruled the world for just a couple of days or a couple of hours, in Scotland we had an illness called, and they were called the Spastic Society. Have you heard that phrase? Spastics. A more ugly phrase you could never conceive. But you know what? Dementia contains that very powerful negative. There's a fear around dementia. A demented person 100 years ago would have been locked up because they were demented. It carried overtones of inadequacy. And so for my 2 days as in charge of the world, I would just scrap dementia and we'd have a vote in this room to find out what we could call it. Now, these issues matter, and they certainly matter to the people at the sharp end of diagnosis, because Jim, you heard from Scotland, who's a brilliant professional, they now have to face a situation after diagnosis where the NHS doesn't help. They're in a situation where they may have to sell their house. They may have to do a number of things in terms of their family. And we've developed a system, both in America and in the United Kingdom, where dementia happening to an individual becomes an enormous family pressure that requires some of the experts who are at the table here today in terms of wills and in terms of this and in terms of that. It shouldn't be like that. You know, reference was made to the fact that I did play professional soccer. My grandfather played for the same team 56 years before I did. He fought in the First World War. He came back with badly beaten up in his head. He became an alcoholic. He was a socialist anyway, sorry to use that word again. But then, of course, he became an evangelical Christian. And the theme that he always prophesied to me was about this idea of equality, about individuality. And currently, a lot of our treatment of Alzheimer's doesn't contain these two qualities. And it's not your fault. It's a society that still finds it difficult to come to terms with that particular issue. So in Scotland, we're trying to break these taboos by saying, look, when we're talking about dementia and Parkinson's, Hodgkin's disease, it's about brain health. So let's try and not be as afraid of dealing with this to members of the public who are terrified when the word dementias. They'd rather somebody say you've got cancer, because A, it'll be paid for, but B, there's maybe a treatment around the corner. Pancreatic cancer, no, but some other cancers, yes. So the brain health thing has been a great breakthrough for Scots, because what we're trying to do is enlist those who are vulnerable into what professionals think and what professionals want to do, not to them, but with them. And then from that point of view, we then look at the compendium of where we are. We talked about a cure, long time ahead. But what I've been working on recently is this whole question about when should a person, in some cases forcibly removed from their domestic home that they've been in for maybe 50 or 60 years and invited to go into an institution. There is no doubt you reach a level of care requirements that you need to leave. But part of our brain health strategy in Scotland is to rethink completely, and using the idea of people leaving their home as an ultimate last resort. And often they will go into nursing care, which is hospitalised, instead of a care home. Now, it's not to say that care homes are not needed, of course they are, but it's actually presenting choice to people that are involved so that they're not going to be bankrupt, they're not going to be this. And what we're trying to do in Scotland is to develop, as part of this brain health strategy, we're discussing with actuaries in the financial sector, in the private sector, how we could start to insure against getting a diagnosis. Because for a lot of people, the diagnosis is bad enough, but their whole world just crumbles. Hey, that can't be right, can it? You know, you're living and then one day the sentence comes and then all of a sudden, not only you, your husband. This is the interesting thing about America and about the UK. In Scotland, we have 100,000 people in Scotland with dementia. 10,000 have advanced dementia, which is entirely health, but it's ignored. We're going to double that in the next 15 to 20 years. If you then take a multiple factor for family linked to the people who have the disease, and then you take communities, friends, we're talking about fantastic numbers of people that in some way may be blighted by an initial diagnosis which said dementia. So my plea is always to look to the humanity side. And I'm not convinced of the idea that as a rich world we can't afford these things. Now for a lot of people that may sound ridiculous, political extremism. It's not. It's just common sense. And if we can accelerate the process of getting a cure, that would help. But in the meantime, let me just say something briefly about Scotland. Scotland, I hope that most of you who are involved in the Chicago Scots will think Scotland is a great place. I do, and always will. But interestingly, Scotland is a turning point, because we were heavily involved in the Industrial Revolution, fighting wars. Scottish engineers, Scottish coal miners, like my father and grandfather were coal miners. They made enormous contributions to their industrial wealth in the UK and in Scotland. We had the period of the Enlightenment between 1740 and 1810, where anything that was being invented in the world came from Scotland. And there's a book by an academic in Washington called How Scots Invented the Modern World. I have to confess, there's a bit of license in it. But it's profound of what this small country on the wildest part of Europe, on the edge of Europe, can contribute. And of course, we might not want to discuss the fact that we're heavily involved in the Protestant Reformation. I always tell people the interesting point that in terms of the Reformation, there were more witches in Scotland that were burned at the stake against all other countries in Europe except Germany. Not a fact worth knowing, but you know, we have had a remarkable history in so many different ways. So we're saying to ourselves in brain health, hey, this is the next enlightenment for us. The logic is so obvious. The resourcing can be difficult, but what it does need is political will. And I know that politicians throughout the world, in this country, our country, are not held in high esteem, but they have the key to unlock the treasures that you want to use to make everybody's life better. So in that sense, I just wanted to read you one paragraph from a little paper we're doing on brain health. I can't really reveal a great deal, but there's going to be a major announcement in Scotland from a group of people about brain health. And this thing I wrote, this is our new enlightenment and mirrors the sentiments of the book, Scotland 2070, A Healthy, Wealthy and Wise Scotland, where the benefits of this small nation, thinking about the long term and using its assets to the full, will unlock remarkable benefits. We are a landscape of possibilities, and with the right approach, Scotland will be successful. And we will want to declare that Scotland will play the most important role in securing, in terms of the dealing with Alzheimer's, we will be in the forefront of the cure. Secondly, in terms of brain health, we will lead the world in terms of the clinic setup we have, in terms of the remarkable insights that that can provide for people. And then thirdly, the hope is that with some political, extra political support, we will lead the world in terms of the kind of subjects we've talked about. Now, you may look at me and say, how ridiculous can you be? Here's this 5.6 million little country. But when we take our past, when we take our ambition, when we take this kind of no-nonsense approach that we can't afford it, of course we can afford it. We're wealthy beyond our wildest dreams. So when you add all these ingredients, We're happy to work with our colleagues everywhere, because one of the things that's interested me is about national resilience. We talk about resilience, but often in countries it doesn't happen. We want to create interdependencies. We want to work with anybody that wants to work with us to make sure that the people that you've discussed and talked about this morning get the rich deserves that they should be getting. That's a great ambition, Gus, to have for such a small country. And we'd like to think that, you know, often people say, well, the Irish make a better job of their diaspora than we do. That's true. But there are more Scots descendants in America than Irish descendants. So where the hell are we? Story in Arkansas. I mean, Arkansas is not the kind of New York of the East, but I'm in Arkansas. I'm teaching at Fayetteville. That's the headquarters of the university, and there's a bar there. And on St. Patrick's Day, all their hair is painted in the tricolour, the Irish tricolour. Can you believe it? I mean, this is Arkansas. I mean, it's not, you know, Hollywood, but these are people there. So I'm saying to myself, well, look, in terms of our diaspora, we can work more closely together. In Congress, something like 45 to 50 of the House and the Senate are descendant Scots. And we want to use that, because despite what's happening in America, we want to talk to everybody, be involved with everybody, and that's another great thing that Scotland has done worldwide, is to try and create a new future. So really, I think that we've got great ambitions. I think there's a lot of reality around it, Gus. I think what we've heard today shows that we have the technocrats, and whether it's medicine, and whether it's design, whether it's architecture, what to do the job. But the big thrust must be, you need the resources. And everybody I've spoken to today makes that point crystal clear. It's not that you're going to do less of a job, but imagine if your financial positions were more secure in terms of what you could spend, where you could spend it, and how you can spend it. The world would be a much better place. So sorry it was a bit long of an introduction, Gus, but you know, I'm passionate about the idea that we could do better. And as far as Scotland's concerned, working with the world, we will do a lot better.
Henry, I have so many questions I want to ask, and I may use the moderator's privilege to ask the first one. And then I'll ask others in the room. I'm sure there will be many questions. Henry, you chaired Alzheimer Scotland's Commission on the Future of Long-Term Care in Scotland, and it's a report I commend to everyone. It's terrific. Your conclusion, the concluding line of your foreword in the report talks of long-term care not merely as a response to needs, but as a testament to a collective commitment to dignity, compassion, and social justice. Could you talk about your motivation? Why did you chair the commission, and what values informed your work?
Well, I've been with Alzheimer's as an ambassador for a few years, and I chaired a few commissions on studies. And it was the idea that in terms of long-term care, where there are genuine need, we want to look at other countries. And I've talked about Scotland's global reach, but we can be a bit insular at times. And I think Leslie referred earlier to our work in Japan. And if you look at the Nordic countries, if you look at Japan, you look at some other countries in Asia, and then let's take Germany or Holland, some amazing things happening. And what Scotland, in that sense, has been a bit parochial, because there's often a thing in politics saying, we are the best anyway, so why should we bother with the rest of the world? But in that sense, the Commission was to say, look, let's learn lessons. Different financial systems, and different habits, different ideals, different positions on the journey towards curing whatever. So we looked at those countries, but one of the key themes was that in Scotland, we're trying to move to a position, because the first contribution this morning was about what I can looked upon as illness and the National Health Service. In the UK, we have a National Health Service, but it's really a National Illness Service, because you have to be ill to use it. So what's happening in the UK and happening in Scotland now, and it's part of the long-term care issue, is we're trying to transform the finances so that what we're doing is we're looking at community provision. as near people's domestic homes as possible. We're using all the fantastic resources and skills we have in the health service, but and involved with pharmacy as well, we're putting them into the community. And that didn't seem to be revolutionary, but what you often meet is resistance, because there's very powerful bureaucracies at work. And what we wanted to do was, in a way, over the next decade or 20 years, spend less money on illness and transfer a lot of that resource into wellness and into health as doing it. So that's underway as part of the brain health issue. We've got resistance. So a lot of people feel that, as reflected in politicians' view, that it's not sufficiently important for us to take resources from the health service. So therefore, all the knowledge from abroad, all the different ideas leads us to believe that we want to keep people subject to other considerations in their own home as far as possible. Now that seems to me an uncontestable sentiment that should be done. However, you've then got to be practical and say, well, there will be issues and incidents and reasons why that cannot occur. But let me say, and it might be the same in the US, we went through a period in the United Kingdom where from the 80s and 90s, people were investing in care homes like they would invest in sweeties and cigarettes. It was return on the capital. Now, basically what we want to do on that in Scotland is to get rid of that. And so therefore it's not attacking the individual investors, but what's happening now is homes are being closed because the return on capital is much less than they anticipated, and there's no newcomers coming in to build care homes. So it seems the ideal situation where government funds are limited, care homes are losing their importance in some respects, so we try and look at the opportunities provided and say, right, subject to all these excellent services being at your doorstep, then we will have care in the community in a very real sense. So that, I think, was learned from the studies we did, Gus, and looking at other countries. And I think the Japanese illustrations, because this is the other thing about prevention. There's a big movement in the UK now, as I said, to drop, from the health service to talk about less about illness, talk about healthy people. And it's quite clear that there's a movement in the UK now to say that it applies to everybody. It shouldn't be just people that might have dementia. A healthy body, as Socrates said, needs a healthy brain, and all of that. Now, some of it's so simple. You have to really ask yourself, why have we missed this? And part of it comes back to philosophy, that if we regard people as recipients of care and other issues in terms of dementia, we owe it to them, we owe it to the families, the extended community to do a much better job. So, hey, I'm applauding everything, but on the other hand, we've a ton of work to do, and that should be political-led, it should be resource-led, and I'm mindful of how we got a vaccine in literally a bit of a year where, in fact, things just move very, very slowly.
Thank you, Henry. Are there questions in the room? Lillian? We'll wait for the microphone to come.
I can speak up.
I could hear you.
My heritage is Scottish, but I was, of course, raised in the United States. And I also have a degree in home economics 100 years ago. But one of the articles I read some time back was that one of the worst diets in the world is the Scottish diet. Has that changed at all, talking about healthy people? And then I have...
I say anything further, but no, I mean, this is a great point, because essentially, and I feel too guilty because I was brought up on chips.
Yeah.
You call them fries here, don't you, or crisps or whatever. Fish and chips.
Mm.
We had something called a black pudding supper and chips. And then some people would like to speculate that we put chocolate Mars bars in deep fry, and we also have deep fried pizzas. So you take a pizza, drop it in. Now, I wish I was just being funny, but
No, I know it's true. I've been to Scotland
so
several times.
your key point is that we don't have a healthy diet, but that's part of the transformation, not just for people with dementia, but everybody to live healthier. But there's a political irony in all of us, of course, and it's happened in the US, it happens in the UK. The same time as we're trying to stop youngsters having too much salt, too much fat, too much carbs. Big business
I know.
doesn't listen.
I know.
So what you've got is a very fundamental political issue in the UK where the government is moving, is to reduce the amount of salt. And over time that will make a huge difference because most of the stuff that we, well, not just the UK, it's processed food. And processed food has no taste. And so therefore you've got to throw in all the salts, fats, whatever, to give it some kind of taste. Now that's a highly simplistic view of the catering industry, but nevertheless, it's a dynamic where somebody's trying to do this, but then there's somebody as a counterforce who's saying, oh no, don't be a nanny state, don't tell us what to eat. We can kill a few kids on the way, but keep taking the salt and keep taking the carbs and keep keeping this. And you know, it's like the bigger political issue in the world just now, the very uncertain world, lots of problems. But for all of us, the challenge is, what kind of country do you want? I mean, simple question, what kind of country do you want? What kind of country do we want? And then you come up with some hard decisions. And in the UK, for example, as partly because of politics, I would be saying to some of the large manufacturers of food, no, there's no negotiation. Kids are dying, people are dying, so-and-so, so-and-so, and it's the corporate good measured through democracy that can actually help. But these days, I'm afraid the private sector is on the rise in the US and in the UK, and a lot of the child benefits that we're trying to seek are just not
I
going
have
to
a
happen.
second question, and
Right.
that is, by any chance, was your childhood in some other country, i.e. the United States or Canada?
The United States is my second home. I've been here now 150 times. And my comment these is, love your country, pity about your politics.
It doesn't seem like a Scottish accent.
I don't know how to take that. We'll have to speak later. That could be really grossly insulting. But you know, when I was a kid, from the ages of 2 to 15, I did nothing except play football, soccer, round ball. I did nothing. I didn't like school. I couldn't be bothered with it. It was a tremendous. I got French. I got maybe 15% out of whatever. When I left, I signed for Leeds United, a professional English club, when I was 14 and went down there when I was 15. And on my report card, the head teacher wrote, "Thank goodness the boy can play football because he's absolutely useless at everything else." And so that's my kind of mixed background. And then I realized later on that maybe football was not going to take me to the high echelons of where I think I am these days. So I had to go to university and just get real for a while.
Henry, we've got 5 more minutes.
Sorry, I'll make my answer shorter.
I wanted to make sure that we got around the room if there are any other questions. I see one at the back. I have another for you.
Oh, there's a... Yeah.
So we talked a little bit earlier when I came in about the economic differences between the US and Scotland. Wealth distribution in Scotland is achieved much more through government and taxes, etc., than it is here. But in terms of combating the disease, the amounts of capital required for research, etc., in a time when your healthcare system doesn't recognize dementia as an illness, and when government investment's been cut back all the time, and you don't have the same kind of pool of philanthropic capital that we have here, where's the money going to come from to do this?
Right, well, the interesting point about this new brain health strategy in Scotland, we need government, but they're not essential. This is the big difference, because Scotland is regarded as a pretty socialist-based country. You know, we care about the poor and we do this and do that. But what you've got in Scotland is a unique combination of an academia with 21 universities that all talk to each other. We have a situation where the third sector, which is the kind of charity sector, is very powerful, skillful, and a great contribution it can make. Political help would be fine. But the other big issue that we've got is we're reaching out, and this is the interdependencies we're trying to create with Big Pharma in America. What we also have is the key point. We have an integrated health service that has massive amounts of data. So for testing purposes, that's just sitting there. Now there's some bureaucratic resistance from the health people, but Big Pharma over here it wants to be in Scotland, because what they suggested to me that there are 5 countries in the world, one of them being Scotland, where the database, the interrelations between academia, a government which is okay, supportive, and then a third sector which is better than normal. We've got the ingredients, so what we're trying to do is to say, right, and if government wants to provide more, fine, but this is not based on government, it's an actually brain health strategy which works on its own. But any extra cash would be very, very good for us. And that's why I mentioned earlier about where we've been in history, because I can't believe the DNA of entrepreneurialism has died in Scotland. I mean, it can't be the case. I mean, in football it has. I mean, we've got a terrible football team, but we qualified for the World Cup, so I'm excited by the fact we might end up playing in Mexico, Canada, or the United States. So that DNA is gone. But I don't think, in terms of where we were as a nation in the 18th century, the 19th century, and when you think of David Hume, there's an amazing number of Scots. So what we're trying to do in a way is to recreate that sense of it doesn't have to depend on government, which is quite forward thinking for Scotland, because we are a country that's viewed as being socialist, we're being left, etc. And a lot of people will be surprised at the outcome of what we're trying to achieve. We still think humanity is important, but we're going to do it without the government.
And unless there are any other questions from the room?
Oh, the lady here.
Oh, Lisa. Thank you.
Thank you so much. This is less a question than a comment and an observation. It was really refreshing to me to be in a room with such big thinkers and big doers and not have a conversation about technology. Clearly, technology will support us as we support, well, if used properly, will be able to support us as we support people living with dementia and hopefully advance that opportunity. But I think what I've heard today is it's a human issue, and it will likely be a human solution to help really incorporate the value and destigmatize and provide more holistic and comprehensive supports for people with dementia and their families. So I kind of applaud us for not going down that rabbit hole today.
Well, I mean, I'm a great deal more cynical than you might ever be. I like the idea, they talk about artificial intelligence, and I got involved recently in, it's called the Institute of Cultural Diplomacy. It's based in Berlin and New York. And we went to a robotarium. We have a robotarium in Scotland at Heriot-Watt University. When you walked into the room, there's this model, and she says good morning to you. She speaks this and speaks that. But anyway, it got to the point about social care. And it was a care institution where nobody would do anything menial. Everything would be done by robotics. But then I thought to myself, in terms of the future, human intelligence, I think, is crucial, artificial intelligence, and they're now talking, and I don't understand a word of this, quantum intelligence. So experts around, that's going to be the next big development. But my concern is how much of that is in any way being controlled by the humanity issue. Because if you take the United States and the UK, the number of people that can't read or write would shock you. Absolutely shock you. You wouldn't think you're living in the same country, but it's massive. Clearly, as the age progression goes through, more young people have access to education, so therefore the figures are going down, but it's in its millions. So my concern is that, yeah, let's do all of that, but let's make sure that the benefits are to the health service, to whatever we're talking about. Because if you leave it to the Elon Musks of the world, partly I think he's crazy, right? I'm not sure what the other part is, but it's equally worrying. So if you leave it over to these people, democracy doesn't count for much. It's big tech, and I'm quite cynical, you know that about technology. But on the other hand, democracy, the people have got to have some control over what's happening in our name. Because if we don't, there's going to be a massive number of care assistants who are not going to have a job because it'll be robots flying about. And can robots stop it? as we did yesterday in the care home, and have a chat with the people? Maybe, but it'll be a pretty soulless chat. So, hey, I think there are warning signs that we've got to go cautiously. If it can help healthcare, which it will do, if it can start up, issues that we're doing, process them quicker, that'll be great. But where does it end?
Just wanted to share something.
By the way, Charlie Gonzalez is chair of our board.
Okay.
Happened to be on my way to the symposium. I parked in the parking lot as Dawn instructed me, and as soon as I got out of the car, I had no idea where I was supposed to go, and I asked a young woman who looked like she was walking to class if she could direct me to the Chris auditorium. She says, I'll do better than that. I'll walk you there. I'm on my way. So as we were walking, I, of course, asked her what she was studying. She said art, and she told me a little bit about her interests. And then she asked me what I was doing on campus. And I said, I'm attending a symposium on dementia and Alzheimer's. She said, really? That's fascinating. I've been reading about how art can really make an impact on people with dementia and Alzheimer's. And I'm very interested in seeing how I might pursue that, either personally or professionally. And I thought, wow, the next generation is really thinking about how they can make a contribution. And having a mother who suffered from Alzheimer's and passed away last year, I saw how my young children played such a pivotal role in helping to manage her progression at very difficult times. So I just thought I would share it. It certainly brought a smile to my face when I walked into the building, and also want to just thank everyone for being here. Right Honourable Henry McLeish, your presentation and those of all the panelists was fascinating, and I'm excited about, as you said, the next enlightenment.
Could I just make a brief soccer contribution to that, to maybe bore the ladies here? But it's about the unknown. I mean, I know I'm not, as I said earlier, I'm not a specialist in anything. I'm a politician, which obviously takes me down in the world. But if you look at someone, and at Hampden Park, Glasgow, which is the home of Scottish football, it used to hold 130,000, now only 50,000. But they have an Alzheimer's group. So they have 40 people coming in maybe every 2 weeks with their carers. And I'm trying to illustrate the point that we really don't know what's in here. So, and often long-term memory is often quite sharp. So in 1960, when I was 12, I went to see the best soccer matches ever been played on the planet. Real Madrid versus Eintracht. I won't bore you with the teams, but I'm going to anyway. So I'm in this Alzheimer's group, and I've got to speak to them about soccer. So I said, look, I'll test them out a bit, see if what the memory situation is here. So I said, look, the team that night of Real Madrid beat Eintracht 7-3. It was like watching the Harlem Globetrotters. It was just fantastic. So anyway, the Spanish team was Dominguez, Marquitos, Passion, Vidal, Santa Maria, Zaraga, Canario del Sol, Di Stefano, Puskas, and then I paused. And this guy said, Hento, and that was a left winger. So this was him after 50 years. Now I know that there's long-term differences, short-term differences, but can we not accept there's maybe an unknown quality lurking in there, which maybe not be very scientific? And that's one of the reasons why I think my original comment was, I'm still here, and let's work with them to explore their possibilities instead of thinking we have all the answers to what they're doing.
I know we're a couple of minutes past time.
Right.
I wanted, on behalf of all of us here, to say how big an impression you've made today, as have all of the speakers. Mm-hmm. You came to visit Caledonia yesterday. We went to the McLean House, and Karen, Henry's wife, is up in the back row, and I need to make an apology to you because Henry made an impression on one particular resident, and when he showed up, she grabbed Henry's jacket and said, "You're a handsome man."
So you made quite an impression on
You know,
us all.
I said to the lady, I said, you made my day, but you need to go and get your eyes tested. You know? She thought that was quite...
Can we all put our hands together for all of the speakers? To the Scottish Government, to the Cott Foundation, the Russell and Josephine Cott Memorial Charitable Trust, to Lisa and her team at Concordia, and to all of you, both in the room and watching online, this Scotsman thanks you from the bottom of my heart. There will be a report of today's proceedings made available in the weeks to come. But thank you very much for braving today's cold and to being with us today. Thank you.
Thanks, Gus.